So, good evening, everybody. Nice to get you back on the second consecutive day of our virtual conference. And so today we have breast cancer, ovarian cancer in Hall A, and with a lot of topics. And so there's a Hall B also where hematology and head and neck cancer is going to be discussed. And so it's another exciting evening for us with a lot of topics to be discussed. We'll be starting with Dr. Ulas Batra, who will be discussing the picking the right strategy for patients with hormone receptor positive PIK3CA mutation breast cancer patients. And so this would be followed by many more talks, and where we have use of PARP inhibitors, and then there are two sessions for CDK4/6 inhibitors, and there's a panel discussion on HER2 metastatic disease sequencing, and there is a bit of molecular biology for breast cancer. And so there are, in ovarian, we are again discussing PARP inhibitors, and there's an exciting panel discussion as well. So where we'll be covering the HIPEC and maintenance therapies, as well as use of PARP inhibitors in advanced ovarian cancer. So to begin with, we have none other than Dr. Ulas Batra, who is a renowned medical oncologist in the country. And Dr. Ulas is a senior consultant at Rajiv Gandhi Cancer Institute, New Delhi, and is a very dear friend and colleague. And Dr. Ulas would be discussing the topic, picking the right strategy for patients with hormone receptor positive, HER2 negative PIK3CA mutation. And so this session is sponsored by Novartis. Ulas, please go ahead.
Okay, thank you, Sachin. I think I'm the opening batsman today, and I hope I don't suffer the same fate as Virat Kohli did yesterday and prior to that. So I hope I am more of a butler kind of a thing for Rajasthan Royals rather than the Kohli for the RCB. And who would have
it so closely, huh?
Oh yes, I am. I mean, oncology is just for fun. The passion is in cricket and Bollywood. Okay. So I have been asked to talk about picking the right strategy in HER2 positive, HER negative metastatic breast cancer. And when I first, saw this topic, my first reactions on this was like this girl. And I say this girl is like a hormonal positive CA breast. She already has tamoxifen. She already has AIs. She already has CDK4/6 inhibitors. And now she wants more. So, I felt, especially with someone who has a keen interest in lung cancer, I mean, the girl is getting a bit too greedy. So that was what my first reactions were. My subsequent reactions of them were when I looked at the data, and I actually saw that on CDK4/6 inhibitor, the bahubalis of breast cancer, only 39% of patients remain progression-free 2.2 years after treating with endocrine and a CDK4/6. So definitely these things are good, but there is definitely a need for a second line thing, because if your Rohit Sharma and Bumrah don't play well, then you need to have a plan B, which Mumbai did not have, and look at where they were. So definitely you've got a point over there, and definitely we need to have a second line and third line management for them. So this is also one of my favorite slides as far as the Alpelet data is concerned. It basically says about Obama, the honeymoon is over. So basically, in short, solar trial actually starts after the honeymoon with the first line endocrine therapy with the Mona Lisa ends. So you have a trial, we have CDK4/6 inhibitors, the Mona Lisa trial. After that ends, what happens to that? That happens the solar. So let's learn about the PIK3CA pathway in breast cancer. And as usual, I have 6 major questions: who, what, when, where, why, how, to answer this. Now, let's talk about the importance of PI3K pathway. Now, is the PI3K pathway important? Yes, it is important. Why is it important? Because 40% of patients will have a PIK3CA mutation, which leads to an hyperactivation of the PI3K and the subsequent downstream pathways. Now, that's very, very important. And why is it important is because if you have a PIK3CA wild type versus you have a PIK3CA mutant, you have a median overall survival of 19.6 versus 23.5 months. So PIK3CA pathway, if it is mutated, is a bad prognostic factor. That is something which we need to understand. So Now you know the problem. Answer is very, very simple. Block it. It's almost like, back in our college days when the girlfriend didn't like you, block it. Doesn't make much of a difference. However, life is not really as simple as that. Our plan usually in the life is like this, going on a cycle, a smooth ride. But the reality, the life is, and I think almost all the medical oncologists will agree, especially who are in the corporate sector, life is never in a smooth one. And I'm sure Sachin will also agree with me. Life is full of crests and trough and more troughs and more crests. And that is what actually happens. So let's look at the development of PI3K inhibitors in solid tumors. It's not something which has come up in the last 1 or 2 years when Novartis has come back with alpelisib. It has been there for a long time. You had a pan PI3K inhibitors, then you had a dual pan PI3K mTOR inhibitors, and now you have an isoform specific inhibitor. So you started with biparlisib, copanlisib, pictlisib, pilarlisib, then you went into apitolisib, then you went to giratolisib, and the other drugs, and now you are coming to isoform specific things. Now, in the first line, when the biparlisib was fulvestrant was compared, there was a failure because the median PFS was 5 versus 7 months, and the HR also was only 0.78. Now, the pan PI3K inhibitors did not set the stage on fire. So what's the solution? Solution is, please be more specific. It's almost like, we are also moving towards site-specific medical oncologists now, actually. So if you can be site more specific, so let's look at the PI3K structure. Now, in the PI3K, you have two. You have one catalytic subunit. You have a regulatory subunit. The one over here is the catalytic subunit. Now, in the PI3 catalytic subunit, you have 4 isoforms: alpha, beta, gamma, delta. Alpelisib is a specific inhibitor of the PI3K alpha isoform. So, starting from a pan PI3K, you went to dual. Now you are being isoform specific, and that is what is probably most important. That is because then it will not cause that much of side effects, and that is how the tolerability will be better and the efficacy also will be better. So we are being much more specific as far as the preclinical rationale of that is concerned. So, but as we all say, the proof of the pudding lies in eating. Now, this was the SOLAR-1 trial, which basically took patients who had progressed on prior AI. They were randomized. There were 2 cohorts: PIK3CA mutant, PIK3CA wild. PIK3CA mutant were randomized between alpelisib plus fulvestrant, and even the wild type were randomized between the two. The primary endpoint was the PFS. Please remember that a trial is considered plus or minus based on only the primary endpoint and not on the basis of secondary endpoint. That's also something which is very, very important. Important thing, a lot of time people ask us about whether a new biopsy should be done. But please see that more than 90% of the patients in this trial had a mutation from the archival tissue. So that's very, very important. The baseline characteristics were very well matched. A lot of people had lung metastasis, liver metastasis. A prior CDK4/6 inhibitors was taken only by around 6% of people in both the arms. But that is because when this trial was designed, you didn't really have CDK4/6 inhibitors. The data regarding that was not strong. Both the primary and the secondary endocrine resistance was basically taken in the subgroup. Now, what are the results? This is the result: a primary endpoint of locally assessed PFS in the PIK3CA mutant cohorts. The curves separated very, very early. You can see from here, there is a good separation of the curves. And that was there in both the BIRC and the investigator assess. And you can see over here, the curves are separating very, very early actually. And the median PFS was between 11 and 5.7. How can I keep lung cancer out of it? osimertinib versus chemotherapy was also in the AURA trial was 10 months versus 4.6 months. Exactly the same kind of benefit that was being seen in the alpelisib and the versus the placebo arm. What about the overall response rate? The overall response rate in the PIK3CA mutant cohort was much more higher once again, and the response was more than 35 versus 16%. Not even a single subgroup was the one which did not benefit. It did not make a difference whether you had lung mets, bone mets, prior CDK4/6 inhibitor, prior chemotherapy, primary resistance, secondary resistance. The type of mutation didn't really make a difference. Everybody responded to the was better in the alpelisib plus the process arm. Something very, very important: liquid biopsy is coming up in a big way. Now, whether you detect a PIK3CA mutation by liquid biopsy or by tissue biopsy, it did not really make a difference. You had a same PFS of 10.9 versus 11 months in patients who had the PIK3CA mutation. And again, the graph is absolutely fantastic on this. Again, to reaffirm, 90% of the patient did not undergo a repeat biopsy and had the tissue from the primary tumor sites actually over there. So this was there in the year 2018. What changed in year 2020? A lot. And I put a capital T onto that because first of all, the COVID came and which did not really disturb Novartis. Novartis has now tried to go virtual. So that was signs of things to come. What also changed in 2020 was the OS result came. Now, this is what Novartis probably didn't want me to show. The median OS was prolonged by approximately 7.9 months in the alpelisib and the fulvestrant arm. However, this did not cross the pre-specified O'Brien-Fleming efficacy boundary. So even if your p-value was significant, it did not really cross the one-sided p less than 0.0161, and that is why the OS was a negative one. Again, overall OS was subgroups. A great proportion of benefit was actually achieved in patients with lung or liver metastasis. So the higher the aggressive the disease, the great benefit was basically seen over there. And this is what it basically says, that the median OS was 37.2 versus 22.8, and a median, the HR was 0.68 with the upper limit of normal exactly a unity at 1. So time to first chemotherapy also was delayed, which was basically 8.5 months in the alpelisib and the fulvestrant arm. So the authors concluded that there was an 8 months increase in the median OS. The OS was better achieved in patients who had a liver or lung mets. It delayed time to first chemotherapy, and they basically said there was a numerical increase in OS, however, which was not statistically significant. So I think it has really made its place in the treatment of HR positive, HER2 negative breast cancer, where PIK3CA mutation is present. However, as I told you, the initial one between aura and this, if it's so good to be true, there is something wrong. Alpelisib is not gefitinib. Alpelisib is not imatinib. Alpelisib is not osimertinib. Now let's look at the AE profile of that. And if you can see over here, grade 3 and grade 4 AEs, especially in the terms of hyperglycemia, diarrhea, and rash, were seen in a high proportion of patients. Actually, 25% of patients actually, had to discontinue alpelisib. Majority for hyperglycemia and 3.2% for rash actually. So this is what I exactly called as, I told you the honeymoon was over. This is what I exactly called as shadi ke side effects. Not everything will be fine. You have to live with it. You have to make some compromises on that actually. So let's get practical. It's a good drug. I obviously say that, but it's not a drug which can be given for everyone. You have to choose your patients very, very wisely. You have to tell your patients, you have to counsel your patients very, very wisely that these are side effects which can actually occur. So the first side effect which can actually come over there is basically hyperglycemia. Now, I always tell my patients that, forget anything, your sugar is going to increase. Why is your sugar going to increase? Because the PI3K basically helps when your insulin binds to the receptor tyrosine kinase. You have the glucose transporter, which basically moves upfront and get the glucose inside. If you block this by RTK, by the PI3K, obviously a glucose transporter will stay inside the cells and the glucose will not come inside, and obviously hyperglycemia will come. I always tell my patients, expect that your sugar will increase. Check your sugar regularly, and the sugar will get raised probably in the first 2 weeks actually. This was also seen by one of the investigators. Basically, what they basically said was, initially when the trial was done, the HbA1c criteria for inclusion was less than 8%. However, what they did was they modified it to less than 6.5%. They did not take the patients with uncontrolled diabetes. The second smart thing what they did was they recommended topical steroids for any grade skin toxicity and oral antihistaminics basically for prophylaxis. And what they basically found out was that if you have to get a higher grade hyperglycemia and rash, first 2 weeks are very, very important. and diarrhea will come basically later. So I always tell my patients, please be very wary of your sugar, please be very wary of the rash, and I always give them an antihistaminic to start with. Again, if you develop hyperglycemia, it's very, very easy. Do not start them on insulin. Start with metformin 500 mg OD, increase the dosage to 500 mg BD. If it still doesn't control, you can make it 1 gram BD. If it again doesn't work, you can add pioglitazones and the other ones. So the sugar is an anticipated event, but even the treatment is very, very standardized. If we know it, if our patient knows it, things are very, very easier actually. A lifestyle change is very, very important. Ask the patient to walk, ask the patient to make all the, be physically very, very active, and things will be fine. Again, the rashes. They compared, after the initial modification, they basically found out that if you give prophylactic antihistaminics to for the rash, things are much more easier. I always start them on Allegra 180 mg along with Pevicto, and then the things become much more easier and people do not actually get that much of rash. Now, people think, that there will be a good amount of QOL deterioration along with alpelisib, but this was the result of the SOLAR trial, and they basically found out that in the two arms of alpelisib plus fulvestrant with placebo, there was not major differences between the two treatment arms, and that is news. I think we need to get out of our mindset. We need to understand that this is a difficult drug. It's a different drug, and we need to manage these people very, very, very properly actually. So what about alpelisib after CDK4/6 inhibitors? Now this is basically a question because nowadays we are giving CDK4/6 inhibitors to almost everyone. Will it work? So this was the BILIEVE study, and this was something which was presented in San Antonio on 2021. There are 3 cohorts actually, and the first cohort was to assess the efficacy of alpelisib plus Faslodex after cohort A, that is people who had received CDK4/6 plus AI as an immediate prior treatment. And what they basically found out was that the PFS was by and large 7.3 months, 18 months PFS was 22.2 months, at 18 months follow-up, median OS was 26.4 months, and at 18-month OS was 65%. So almost the similar figures which we achieved if you had not given a CDK4/6 inhibitor. So to conclude, I always say, I always started my picture with saying, the girl was hungry, the girl was greedy. But I think Steve Jobs said it very right. Stay hungry, stay foolish, because greed, for a lack of better word, is good. And in the context of cancer, stay hungry for new drugs, better overall survival, and again, greed for a medical oncologist. We want more new drugs. We want oral drugs so that our patients can live longer and they can develop a good quality of life and a better overall survival. So with this, thank you. And I hope I have not acted like Virat Kohli in the last match, and I've acted like Jose Butler. Thank you.
Great. Thank you, Lars. Just a short and quick question. When and how are you going to test for PIK3CA? At relapse or upfront in a let's say it's a metastatic MBC? And so would you do all the tests upfront, or you will wait for relapse to happen and then you will do PIK3CA?
Typically, Sachin, my policy was to do it at relapse. But then I was talking to an international expert over there. He said, what do you lose if the test is being done free? I mean, there are coupons which are roaming around over there. Test is being done free. And Novartis gets the test done free. Since a symposium, I can tell that. So if you have a coupon, there is no harm in having the information with you. 90% of the people, and normally we don't even get the biopsy done. So I'll be absolutely happy. But the point is with CDK4/6 inhibitors, we expect 2 to 2.5 years. So I am now beginning to get the test done upfront, but it saves time and you always have information present with you. That's what.
So is there a change expected? Suppose you do it upfront or
no. That's what. So there is no change expected over there. That is why. It's almost like an EGF or a KRAS testing,
So that is a very important point actually. So we can get it done upfront as well.
In fact, I mean, everybody I met over there in that symposium said we are doing it upfront. ERPR, HER2, PIK3CA. You also will try to understand the biology of the disease. PIK3CA is a bad biological disease. So it's even a negative. It's a predictive factor for the drug. It's a prognostic factor for the disease. So there's no harm in having a good information.
And another important question, do you handle hyperglycemia yourself or you ask your diabetologist to step in?
So we do ask our diabetologist to step in, predominantly because, we don't have the time and patience. But I do tell them, I give them this thing that, listen, this is the way you manage. Please don't put them onto insulin upfront over there. So for all my medico-legal reasons and patients, they will otherwise bother me with their sugar reports, every 2 thing and all. So I do tell them, but I give them a copy of this slide that I have. I tell them, भैया उनके पास जाओ, उनको बोलना ये दवाई दे देंगे. As our surgical oncologists, write the chemo plan and give it to us, 8 cycle chemo. So I also do the same with them.
Great. Thank you, Ulas.
Thank you.
That was really great, and you have done that again in a very crisp fashion and in your typical style, witty, and you made it so interesting as well. Thank you so much for being there.
Thank you.
And so we move on to the next session, and we have Dr. Jatin Surain with us. He's a very dear senior and colleague in Chandigarh, and Dr. Jatin is Director Oncology at Ivy Hospital in Mohali. And Dr. Jatin would be covering the topic, how do I use PARP inhibitors in adjuvant therapy of BRCA positive breast cancer? So Dr. Jatin, you can please start your session now.
Thank you, Sachin, for opening me in for this meeting. Well, it won't be so nice a presentation as Ulas is a seasoned guy. I am just going to be to the point. Let me share my presentation.
So can we share your slides from our end?
Yeah, I think please do it.
Support team, please share Dr. Jatin's slides.
Yeah, thank you. So how do I use PARP inhibitors in adjuvant treatment of BRCA positive breast cancer? So very specific question has been answered in this particular presentation. And next slide, please. Next slide. So BRCA mutations in unselected breast cancer population are around, there are 5% chance of BRCA1 and 2 mutation positivity. And it varies in from country to country, from region to region. Even in India, it varies at different places. Next slide. Next slide. Am I audible?
Yes, sir. So you are very much audible, sir.
Right. So this was on paper find in Indian patients, BRCA mutations. The important thing was that the prevalence of, according to this paper, the conclusions were that the prevalence of pathogenic mutation in breast cancer patient is higher in Indian patients compared with most other patients, most other populations. But the important thing is that data are available to suggest that 50 to 80% of individuals at risk of having hereditary breast cancer are never tested, as they do not meet the current criteria, the current guidelines for testing. And in this particular paper, among the 59 TNBC patients, 13.6% were harboring BRCA mutations, and BRCA1 was in 6 patients and BRCA2 was in 2 patients. Next slide. So what's important? Just like PIK3CA, BRCA mutation patients are diagnosed at younger age. They are of higher, and the tumors are of higher grade than sporadic tumors. These tumors tend to have more CNS metastasis, and they have more contralateral diseases. and also they are at higher risk of recurrence. So it's an aggressive phenotype overall. Next slide. So in the early breast cancer setting, why is there a need for upfront testing of BRCA mutation? So BRCA test actually will help us in tailoring our treatment in early breast cancer, both the adjuvant treatment and even the surgery part can be tailored. The BRCA mutation breast cancer is aggressive, so it has higher risk of recurrence. So preoperative genetic testing impacts the surgical decision making. And now with the particular trial which we are going to discuss, it has impacted our adjuvant treatment also. Next slide. Next slide. Next slide, please.
Supporting.
So these are the NCCN criteria for BRCA testing in hereditary breast cancer. In patients or individuals diagnosed with breast cancer. So for less than equal to 45 and 50 years, there is not much of a concern. We have to test BRCA mutations, and in more than 50 years or any age, you test BRCA mutations in which there is a family history criteria, personal history criteria, or for aid in adjuvant. Whatever are the current guidelines for testing BRCA mutations, we have to test triple negative breast cancer, personal and family history criteria, male breast cancer, ethnicity associated with higher mutation frequency. So this aid in actually the treatment, both in the metastatic setting and also in the adjuvant treatment setting now. Next slide. So this was the landmark study. It was a phase 3 study of olaparib versus placebo as an adjuvant treatment for high-risk BRCA mutated HER2 negative breast cancer. So the eligibility was germline pathogenic or likely pathogenic BRCA1 and 2 mutations, stage 2 to 3 breast cancer, HR positive or Tnbc, HER2 negative breast cancer, who have completed at least 6 cycles of neoadjuvant or adjuvant chemotherapy containing anthracycline or taxane. If it is a neoadjuvant therapy they have received, then in Tnbc, non-achievement of pathological CR. In HR positive, in which pathological CR is not a common scenario, then CPS plus EG scoring. I'll come to the CPS EG scoring of more than equal to 3, then you have to put. And in adjuvant setting, if in Tnbc patient, any pathologically T2 or pathologically N1 breast cancer are eligible, and for HR positive, more than equal to 4 positive lymph nodes are eligible. They were randomized 1:1 with olaparib 300 milligram BD versus placebo. The primary endpoint was invasive disease-free survival, and the secondary endpoints were distant disease-free survival, overall survival, BRCA1 and 2 associated cancers, health-related quality of life, and safety and tolerability. The population was trial population was stratified on the basis of HR positive versus Tnbc, neoadjuvant versus adjuvant, and prior platinum-based chemotherapy or not. Next slide. So, according to this, there were triple negative breast cancer 82% and hormone receptor positive breast cancers 18%. And this is the CPS EG criteria. CPS means clinical stage, pathological stage, and receptor status and nuclear grade. So these were the points assigned according to these thing, and there was a total score of 0 to 6, and 3 or more than 3 was considered high risk. Next slide, please. So this was the result. Olaparib reduced the risk of invasive recurrence or death by 37% versus placebo. The 3-year IDFS rate, the difference was around 8.8%, and 4-year IDFS rate, now the 4-year data is also available, is around 7.3%, with the stratified hazard ratio of 0.63. Next slide. So all subgroups were benefited, as you can see from this plot, and except for the ones who have received prior platinum, the hazard ratios were in the range of 0.79. Otherwise, most of the subgroups, whether they are HR positive or at TNBC, Bracha 1 or Bracha 2 or both, and adjuvant versus neoadjuvant. So all of them benefited and favored olaparib, that was given for a year post in treatment. Next slide. Now, 87.5% of patients treated with adjuvant were free of distant recurrence in 3 years. So this was the one of the secondary endpoints, and so was overall survival, which was the secondary endpoint, and the hazard ratio was 0.57. So distant disease, so this is one of the surrogate marker. How important is this surrogate marker? I don't want to go into the detail of this. Next slide, please. In the second interim analysis, it was shown that overall survival graph tended to separate. So difference in the 3-year OS rate was around 3.8%, while the difference in 4-year OS rate was around 3.4%. And if we calculated the numerically, then in olaparib arm there were 75 deaths, out of which 70 were due to the cancer, and in placebo there were 109 deaths and 103 were due to breast cancer. So stratified hazard ratio was 0.68. So tended to have improved OS. So not going much into the statistical details. Next slide, please. Next slide. Now, adverse event. Previous slide, please. So adverse event, the major adverse event were in olaparib arm were anemia, fatigue, nausea, and diarrhea. All these were there. The grade 3 and 4 adverse event were definitely more in olaparib arm as compared to the placebo arm, and adverse event leading to permanent discontinuation of treatment was there in 9.9 or roughly 10% of patients. So everyone might be having a different experience in this, but this was there in the trial, that adverse event leading to discontinuation of treatment in olaparib arm was around 10%. So next slide. And this was the specified clinical meaningful difference is 3.9 was not met. This was the fatigue severity scores in both the olaparib and placebo arms, and there was a statistical significant difference between the fatigue between placebo and olaparib, but there was not much of a clinically meaningful difference, as they said. So with olaparib, olaparib was found to be in general tolerable compared to the placebo. Next slide. The same with the various other side effects. It was basically not much of a difference. Definitely, there were more numbers of or more side effects with olaparib, but in general, well tolerated as compared to the control arm. Next slide. Now, this was another PARP inhibitor trial, but actually, this was a failed trial. This is a brightness study that came in Tnbc. It was a phase 3 trial, and which PARP inhibitor was used along with chemotherapy, and the primary endpoint was in this was PCR, and secondary endpoints were event-free survival, overall survival, and safety. Next slide, please. So here we can see that the difference between adding carboplatin to paclitaxel followed by doxorubicin and cyclophosphamide improved PCR significantly and translated into improved EFS after a median follow-up of 4.5 years. But addition of veliparib, that is the PARP inhibitor, did not impact either the PCR, EFS, or OS. Next slide. So the conclusions are next. So this was an important trial. Again, you know, in TNBC setting, we didn't have any adjuvant maintenance, except that in the subsets in which we, in all subsets rather, we use capecitabine as an adjuvant treatment, and that has also led to improvement in our DFS and all. But in Bracha positive setting, which are actually a bad subtype of TNBC or HR positive, this has led to improvement in OS gradually. Recent developments in our understanding of breast cancer, molecular biology, and heterogeneity led to substantial improvement in the outcomes. And the value of identifying high penetrance mutation in breast cancer gene is well established, and identifying for germline BRCA 1 and 2 has now moved beyond prevention of treatment. Yes, it was tested just for prophylaxis or prevention, is now being tested for treatment, therapeutic thing in both early and metastatic breast cancer. Next slide. Olympia trial reported clinical benefits of PARP as adjuvant with germline BRCA mutant, HER2 negative early breast cancer at high risk of recurrence. Thank you, and I'm open to any questions.
Yeah, thank you, Dr. Jatin. You have covered that topic beautifully, and it's a very actually confusing thing and difficult to incorporate in practice also. What's your experience in using PARP inhibitors as adjuvant treatment so far? And how do you convince your patients if you are yourself convinced?
To be very frank, I haven't myself put any PARP inhibitor on adjuvant. Very frankly, as yet in the adjuvant, I have discussed with the patient, definitely with the eligible patient, but I haven't put it. But I have seen patients on PARP inhibitors, and one or two of them discontinued the treatment because of the various side effects, and a few of them, just one of them I could see which was tolerating full dose of 300 milligram BD really well, and she was on PARP inhibitor, the olaparib. But yes, there was always a confusion that in triple negative, if there is a non-PCR, whether you go for a capecitabine versus olaparib, and in HR positive with the hormonal therapy, should you use PARP inhibitor if it is BRCA mutant positive? So There are no answers to it as yet. But the thing is that if you have BRCA mutation and if someone is affording and someone is willing to go for it, then olaparib maintenance or adjuvant is a good therapy for such subset of patients.
Good. Dr. Pavitran sir is there. I can see his name. Sir, are you listening? Your thoughts on this? I think sir is not. Dr. Bhuvan? Dr. Bhuvan, are you able to hear us?
Yes, sir. Yes, sir. Sorry.
Yeah. And any comment regarding adjuvant PARP in breast?
So I think what it has made me do is it has made germline testing in even all the patients now, because probably that's the first thing which to be done. Otherwise, probably we used to limit it to the strict criteria, but now almost everybody we are doing germline testing. That's one thing, and the other thing is, yes, it may not be indicated, but those patients who generally have a my only confusion arises when somebody has a high hormone positive disease and turns out to be germline positive. Whether I choose a Monarch E or versus I choose a Olympiad is the only end up confusion which I end up having.
So here
any thoughts on
we are
that?
positive, but high node positive patients were taken up. 4 nodes and
So
above.
same thing.
So high risk.
Same thing with Monarchy also, right? So that's one subgroup which you end up having a confusion.
Okay, so if the patient is germline mutation positive also and HR positive also, then will be probably confused.
So basically, Olympiad had the Olympiad the as in the inclusion criteria was somebody who has 4 or more nodes positive at the end of treatment. That was the diagnostic. That was the criteria to give Olympiad. Olaparib.
So
I think it was almost similar to abemaciclib if you use. Anji?
All right. So we need more information and more robust, and of course the cost of drug again becomes a limitation and not a very easy to use drugs. A lot of side effects in the adjuvant setting, which may not be acceptable to many patients. That's great. Thank you, Dr. Jatin. So Bhuvan, you are next. Dr. Jatin has consented. He had a family, get together also, but still he was very kind to oblige us. Thank you, sir. Thank you so much.
Thank you.
Yeah. And Dr. Bhuvan, would you be parking your car somewhere? How are you going to?
Sir, am I not audible?
You are audible, but are you driving yourself?
No, sir, not at all.
Okay. You are on the other side. That's great. That's fine. So you are going next now. And so Dr. Bhuvan Chok is a senior consultant medical oncologist in Max Hospital, Saket and Gurugram. And Dr. Bhuvan would be talking on the topic from clinical trials to clinical practice, navigating management of hormone receptor positive MBC with CDK4/6 inhibitors. So Bhuvan, you can go ahead.
So thank you, Sachin, for giving me this opportunity. And so CDK4/6, I think it's close to everybody's heart these days because it's one of those drugs which has made life easy in hormone-positive breast cancers. And it's really a treat to have this drug because suddenly you have a drug which works good for 2 years and 2.5 years, and you are you can be easily. Sorry, I think I lost my screen. One second. Is my screen visible now, sir?
Yes.
Yeah, thank you. So I think that's the reason probably incidence of breast cancer being in general the second most common cancer, and in females especially the most common cancer, it is still not the most common cause of mortality, and it's primarily because of the drugs which are there. Generally, a hormone positive breast cancer, we can easily say in today's world and era that they're going to survive around 4.5 years. And that's all credit to the drugs such as CDK4/6. And I think we all understand that it is the most common cancer in females, and it is lower down when it comes to the mortality. And in India, it's the most common cancer now. I think it has been long been replaced. It has toppled cervical cancer, which was which was the most common cancer up to 2012. And then 2018, and the data after that has shown that the breast cancer is the most common cancer. 30% of the women, they tend to relapse, and it's a common figure. So whenever we have a woman who's early breast cancer, what we need to keep in mind is almost 1/3 of them, probably 30%, will end up with a metastatic disease, and almost 6 to 10% of the cancers, women, they tend to present with de novo metastatic disease. We also understand that there are these two groups of hormone positive women. One are the indolent kinds who have a long disease-free survival. They tend to relapse after 7-8 years, and they have, if they relapse, they'll probably relapse with a bone-only disease, and that suggests that they are primarily sensitive to endocrine therapy. And there are these, luminal B aggressive hormone-positive cancer women who had rapid development of metastasis. They generally take hormone therapy for 1.5 years, and then they tend to develop metastasis. And these are the women which we are really scared about. So, what we need to understand now is, in today's world and era, I don't think there's anybody who will want to be in a debate where it's going to be chemotherapy versus chemo or endocrine therapy. It's going to be a endocrine therapy with a CDK inhibitor. Now, coming to the management of hormone-positive breast cancer, we all understand that anybody who has a metastatic hormone-positive breast cancer would be given a first-line endocrine therapy plus a CDK inhibitor, unless the disease is very, very mild. So, which, and probably I'll have to debate that also, whether you'll be sticking only to endocrine therapy or going to be going endocrine plus CDK both. What I would like to talk in today's world today is that we all understand. We'll just show you some data in terms of the three CDK inhibitors which are there, and then move on to what to do in second line. I think that's where the thing also becomes very exciting with the trial data coming in, which has compared fulvestrant versus capecitabine, Anyway, so moving forward, I think we all understand the pathophysiology of CDK inhibitors. The CDK inhibitors are basically a drug which which they act on the cell cycle of it. They tend to push the cell cycle. They tend to push the the breast tumor cells into senescence, and that's primarily because there are a lot of pathways which almost converge upon the cyclic D, and that's where the CDK4/6 inhibitors act. There are obviously a number of phase 3 trial data. I think these have been harped and these have been hampered so much that we all understand, we all by heart know which are the first line. So basically, the first line trials are Paloma 2, Monarch, Paloma 2, Mona Lisa 2, Monarch 3, and Mona Lisa 7 are the 2 trials, are the 4 trials. And I think we all use these 3 drugs, almost consistently. Palbociclib, abemaciclib, ribociclib. These are the 3 CDK inhibitors which go head to head. And there is no particular one drug which can be chosen or the other. In the second line, we have obviously the Paloma 3 data, which has been given, in which the partner drugs are fulvestrant. Now, there is a pooled analysis shown that across all the trials, the hazard has ranged from 0.51 to 0.64. There is no reason for us to not use a drug which is almost giving a 50% relative benefit as compared to a single agent AI. What I would also like to bring about is the subgroup analysis, and this is where the science shows its effect. If you have a bone-only metastasis, it shows that the patient responds the kind of response patient have is much better when you obviously give AI plus CDK. However, patients who are less than 40 years of age, patients who have lung or liver metastasis are the subgroups which we generally know they're not going to respond better, or they are not going to respond as good as to the CDK as the bone only would have responded. There is enough data to also suggest that in the bone only metastasis, all the 3 almost go head to head when it comes to adding the AI to CDK. Now, coming to the partner drug, it's all about the comfort, and we generally as a thing, we start the patient on an AI, and that's where we take it as it's still not changed our practice as such, because however there's the trial data. I'll just take you there. So I think there is this, I'm just missing the slide, but there is this trial data which says that eventually you can either use a AI or a fulvestrant, you will probably get the same result. I think I'm missing the slide somewhere. Anyway, so, but then it's our comfort that we end up choosing a oral drug because there's slightly more benefit with the letrozole as compared to fulvestrant. I'll have that slide come up somewhere. Anyway, moving forward, the toxicities of it, I think we all are clear about it. When you use a PAL-base, the major toxicity is uncomplicated neutropenia, which I've not had a problem with. However, this one-off patient, they have extreme fatigue to it, and probably changing a CDK inhibitor does have helped in my case. Ribociclib, I think, again, the neutropenia and increase in the QTC is what we need to figure it out. And Monarch 3, I think, and abemaciclib, I think the only toxicity which probably happened more in the Western population and didn't happen in our population was diarrhea. I probably, the amount of concern which we had in terms of diarrhea as being a toxicity in terms of abemaciclib probably has not come to an Indian population, at least for me. The way we obviously monitor this is that we keep the patients on day 1 and day 14. So we call the patient every 15 days for the first 2 months, and then beyond after that we call it for at the start of beginning of the cycle for the next 4 cycles, and then it's almost once in 3 months. I think that holds true for almost all the drugs. It's just that for abemaciclib, they also recommend that repeating LFTs every 15 days. So coming to it, selecting the drug, I think there are these 2-3 lines which I've tried to concise this entire thing in. It's probably not there in this, but then the first thing is in a patient who has a endocrine resistant setting, there is some bit data that abemaciclib tends to work a bit better. That's also because because the Paloma 3 didn't show an overall survival benefit when palbociclib was used in the second line along with fulvestrant. So probably in an endocrine resistance setting, I would probably tend to marginally favor abemaciclib over the others. When it comes to the second line setting, if you look at the data, I'll just try to show you. So when it comes to abemaciclib, tends to perform much better. So my go-to thing is if the patient has kind of progressed very that's the question, and the patient is obviously PIK3 wild type. So that's a very peculiar clinical setting which most of us find us in, because most of our patients now, we tend to use AI plus CDK in the first line. And once we have used the ADI for the drug in the second line, obviously the first thing which we do is we send a PIK3. If the PIK3 is positive, I think the life becomes easier, because the next line of therapy automatically becomes a fulvestrant plus alpelisib based on the SOLA-1 trial, which gives you around 10-11 months. But if the PIK3 is wild type, what do you do then? Do you go for fulvestrant only, or you go with capecitabine? I think that's an interesting trial which was published. I think it was Peace trial, or it was I'm forgetting the name, but it did show that capecitabine in such a patient responded or had a good benefit there. However, the toxicity was much better, much more. My go-to is that in today's world and era, irrespective of the visceral disease which is present or not, I would end up choosing a CDK inhibitor over chemotherapy in almost all cases. It's very, very rare. I probably don't know in what, it'll really we have to. So what I think is, if the disease burden is so high that there is a lot of visceral metastasis, and I have that window where I need to act fast, is the only reason I'll give a chemotherapy in a hormone positive. Otherwise, it's entirely AI plus CDK or a hormone therapy plus CDK. So I think toxicities are not a concern. It's only for the elderly people that it becomes a bit difficult. So in that, obviously, there is a dose reduction which is readily available, and then you kind of decrease the dose a little, they manage it well, and then you move forward. So again, coming back to treatment effects of palbociclib by plus endocrine therapy, there's obviously some data to suggest that the patients tend to respond better if they are in luminal A as compared to luminal B. That's because it has also been shown, I'll just take you the trial also, yeah, this one. So it has been shown that the patients who had a lower grade disease, they tend to perform better as compared to somebody who had a higher grade disease. Also, patients who had who were progesterone receptor negative, they slightly had a slight edge over the progesterone receptor positive patients. So again, I think this we already spoken about, and in visceral metastasis, we all understand that yes, they may not perform as bone-only metastasis, but we also know that there is a good amount of data, and we all have a clinical experience in terms of advising a CDK4/6 inhibitor in somebody who has a visceral metastasis. Again, I think when abemaciclib came to market, there was this discussion I was having with the Abema Lilly guys that we are going to place the drug. And I think abemaciclib has really kind of made a niche for itself in the patient who has had a visceral crisis and where the disease burden is high. And it's probably because of the way they have presented the data, and the data has been extrapolated. Again, I think coming back to it, ribociclib again is a good drug which can be given, and there is no reason not to give it. And there's a good real-world data also which suggests that use of CDK4/6 inhibitor in the first-line setting, irrespective of the visceral crisis or not, is the go-to drug, and there is a good 18.1 months PFS with that. So these are these multiple papers about it. So coming to the resistance of CDK4/6 inhibitor, so coming in presented in this year SABCS, what has happened is there's a lot of there's a lot of pull towards the ESR1 mutation inhibitors, and what I probably end up doing is if the patient has been, there's no data to use it in clinic, but then somebody has been rapidly progressing through the endocrine therapy, I tend to pick it up. I tend to tend to check for the ESR1 mutation and choose fulvestrant over AI. So I think that's my talk, and thank you so much.
Thank you, Dr. Bhuvan. You have set the stage for CDK4/6 inhibitors already. And so we know the hazard ratio for the, but again, all these drugs have, various, differences in toxicity profiles and some niche areas, as you already pointed out, for abemaciclib, for ribociclib, etc. And so we do have some pointers which can help us to pick and choose in, these drugs in various situations. And thank you, Dr. Bhuvan. So the next session is actually going to be a little similar. And so this is a Lilly sponsored session, and I'll be moderating and presenting this. And my colleague, Dr. Samit Purohit, is with me. We'll be presenting a couple of cases here and followed by a discussion. And let me share my screen here. So my slides are visible?
No, sir. Please
No,
share
sir.
your screen, sir.
Now?
No, click on share screen button, sir. A green color button at the bottom side.
No,
Then click on first option screen,
I've
sir.
already done that. What is happening? So.
Yeah, now you're done, sir.
Okay. All right. So look, the weather here is pretty, it's raining here. I think there might be some disturbance on my end, probably, huh?
So we can do from our side, sir.
You can hear me?
Yeah, we can hear you perfect, sir.
Okay. So if there is any problem, then you can take over from there.
Now only click on resume slideshow, sir. Because we are unable to see your slides in slideshow mode.
Now?
Yeah, now we can see, sir. Perfect.
Okay, good. So cancer does not take a day off, then why should a CDK4/6 inhibitor? So this is the title of the talk, and we'll see how abemaciclib has developed a niche of its own out of all the three CDK4/6 inhibitors available to us. And so Ramivan, as it is called. So we'll be discussing two pivotal trials with the abemaciclib. One is Monarch 2, other is the Monarch 3. And so beginning with Monarch 2, it's a randomized double-blind placebo-controlled phase 3 study, and fulvestrant was used with the abemaciclib or without. And so this is meant for hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer women. And to see the design of this trial, so hormone receptor positive, pre and perimenopausal as well as postmenopausal. Of course, we use GnRH agonist here for pre-peri, and ET resistant. So how do we call endocrine therapy resistant? Relapsed on adjuvant or on within 12 months of adjuvant endocrine therapy, or progressed on first line endocrine therapy, and no chemo was allowed for advanced breast cancer, and no more than one type of endocrine therapy for advanced breast cancer, and good performance status. Nearly 669 patients, 2:1 randomization, abemaciclib 150 BD. So the initial dose of abemaciclib was 200 BD, but after the toxicities was seen, the dose was decreased to 150 BD for the ongoing as well as the fresh patients enrolled. And the primary endpoint was PFS, with secondary endpoint for OS and safety, and some other endpoints of PFS2 and time to chemotherapy. And stratification according to visceral, the sites of metastasis, visceral versus bone only, and endocrine therapy resistance, primary versus secondary. And so it was a multi-centric, multi-country trial, 19 countries, 142 centers. And so let's see the disease characteristics here for endocrine therapy resistance. So nearly 25% patients having primary resistance, and there were a lot of patients having progesterone receptor status negative. So nearly 21.5% here. And majority patients were having visceral disease, 55%, and about 16% patients were pre or perimenopausal as well. So good number of patients here. Now the primary endpoint PFS, if we see median of 16.4 versus 9.3 months here, and with the hazard ratio of 0.55. And if we see the subgroup analysis, now the primary endocrine resistance faring better than secondary, the progesterone receptor status negative, again getting even better benefit than PR positive group, and visceral disease patients again getting better benefit than bone only disease. So these three, the highlighted areas need to be looked into. And of course, all other subgroups did benefit. And if we see the change in tumor size, again, the overall response rates with abema plus fulvestrant 48% and CBR of 73 versus 21 and 52% here. So decrease in tumor size was again very impressive. And the updated PFS, so nearly 30% versus 10%. And so this is at 3 years, and hazard ratio of 0.536, which is again an impressive hazard ratio. And OS results at interim this thing. So if we look at this 46.7 versus 37 months, so good 9.5 months survival benefit data is now available, and which is again a very significant advancements and overall impressive result. Now, OS in subgroups by stratification factors. So if we look at visceral and the primary resistance, we see the benefit in visceral disease is again better. And if we see primary resistance cases, again, the benefit favors abemaciclib. So here, let's have a look at the what do you mean by primary as well as secondary resistance? So these definitions are again important to learn. Now the primary resistance is the relapse while on the first 2 years of adjuvant endocrine therapy, or progression within first 6 months of first line endocrine therapy for MBC while on endocrine therapy. And secondary is when the relapse is while on adjuvant ET, but after 2 years or within 12 months of completion of the adjuvant endocrine therapy, or after 6 months of endocrine therapy for MBC while the patient is on endocrine therapy. So I hope these definitions are clear. These are important to understand for these trials. So visceral disease and primary resistance patients are getting better benefit in favor of abemaciclib. Yeah. So here are the hazard ratio for visceral disease, 0.67. And for endocrine therapy resistance, for primary resistance, the curves are diverging. And the benefit is much more with abemaciclib arm. And for exploratory endpoint time to chemotherapy, again, here again we see that from randomization to initiation of first post discontinuation chemotherapy, so a good 50 months median here versus 22. So these patients can delay chemotherapy much longer as compared to the other treatment. So majority of patients will not require chemotherapy for many, many years. And coming on to the side effect profile, so abemaciclib, for let's see at the grade 3 and grade 4, if we look, the diarrhea and cytopenias have been the major side effects, but manageable. And cytopenias, again, if we see neutropenia and some kind of anemia, which were again not difficult and were manageable. So to conclude, for Monarch 2, the addition of abema to fulvestrant provided a statistically significant OS improvement, right? And the median OS benefit nearly 9.5 months and consistent across subgroups, including with patients having poor prognostic factors such as visceral mets and primary endocrine therapy resistance. And after a median follow of nearly 4 years, still 17% of patients with abema arm remained on treatment, right? And it significantly delayed the receipt of subsequent chemotherapy. And so the continued follow-up is ongoing to further characterize the OS benefit and exploratory efficacy endpoints. Now coming to Monarch 3 data. So this was abemaciclib when tried as an initial therapy for advanced breast cancer. And so here the subgroup, the only post-menopausal patients were taken up who were metastatic or loco-regionally recurrent with no prior systemic therapy. And if neoadjuvant or adjuvant endocrine therapy were administered, there was a disease-free interval of more than 12 months after completion of this. And so the dose used was 150 BD with anastrozole or letrozole, and nearly 500 patients here. And the primary endpoint of PFS, secondary endpoint of OS, and again, stratification according to the metastatic sites and prior endocrine therapy. So here we see significant improvement in median PFS versus placebo. So nearly doubling of median PFS, 28 versus 14.8 months here, with hazard ratio of 0.54. And if we look at the PFS in pre-specified subgroup analysis, here again we see that in all the subgroups, whether it's visceral or bone only, whether it's prior aromatase inhibitor or prior other endocrine therapy, de novo mets or recurrent disease versus age, geographical, and PR status positive or negative, across the subgroups, abemaciclib did show good benefit. And again, change in tumor size, the overall response 61% versus 45% here. And consistent PFS results. So looking at the data for liver metastasis, here again, the PFS in women with liver mets, again impressive, 15 months versus. So this liver metastasis patients is a poor prognostic subgroup. Here the benefit was again doubling of median PFS and hazard ratio of 0.54. And if we look at change in tumor size by cycle, we see that there is within, let's say, 2 to 4 cycles, there is significant change of the size. And so responses were observed early and they were maintained and led to a substantial tumor shrinkage here. And side effect profile is, as we see before, mainly diarrhea and neutropenias, which were again well manageable, as we see in our own practice also. So to conclude, abemaciclib plus letrozole or anastrozole significantly improved PFS and overall response rates, and in initial therapy of MBC in postmenopausal, and the benefit was consistent across all the subgroups, and responses observed in patients who received Ramiven generally occurred early. So we got early responses and the responses were maintained. And the safety profile was well tolerated and consistent with other studies. So this was from my side. I would invite Dr. Samit Purohit, who is consultant medical oncologist at Action Cancer Hospital in New Delhi. It's my dear colleague, to present a few cases, and so we'll be discussing these cases and about usage of CDK4/6 inhibitors, and followed by some more questions. Dr. Samit, please.
Thank you, Dr. Sachin, for having me on this forum, and I'd like to just share my slides here. So can you give me the rights for sharing the organizers, please?
Yeah, now you can share, sir. I stopped share of Dr. Sachin, sir.
So my slides are visible?
Sir,
Yes, sir.
go to
Yeah.
slideshow mode, please, sir. Yeah, done, sir.
Great. So these are my disclaimers. And my first case is a 59-year-old post-menopausal female presenting with complaints of backache and weight loss for last 3 months. And this was on examination. She was found to have a breast lump around 2 into 4 centimeter with ipsilateral hard and fixed lymph nodes. The breast biopsy, which was done, was suggestive of IDC, hormone expressive, PR of 70%, PR of 50%, HER2 3+, and Ki67 index of 30%. PET scan was suggestive of multiple bony mets and bilateral lung metastasis. So this was somewhere outside. So what happened was patient was offered anti-HER2 treatment for 3 cycles, and she had a partial response. And thereafter, a repeat scan for after 3 more cycles, that is a total of 6 cycles, she had a progressive disease. And there was increase in breast lesion along with few new lesions. So subsequently, she was put on second line anti-HER2 for 3 cycles. However, PET CT in November 2021 suggestive of progressive disease in breast lungs. We were able to do a repeat biopsy from lung, which suggested that it's a metastatic adenocarcinoma, PR of 70%, PR of 30%, and HER2 was negative. So this was the baseline PET CT. These are the lung metastasis and these are the bony metastasis. So this was after 3 cycles of second line anti-HER2. There was disease kept on. This was after 3 cycles. Then there was some response. The disease had come down. Again, it progressed. So we did a rebiopsy, and then the patient was offered abemaciclib plus letrozole plus zoledronic acid. So my early experience was that patient was able to cope up with the drug quite nicely. The more discussed side effect of diarrhea was not seen. Patient became clinically better. There is reduced breast swelling. Appetite had become better, and patient had gained weight. Somehow the patient belongs to a very remote village in Rajasthan. So this is as of clinically, and we have tried to call the patient again to do a rescan, but clinically the patient is now better, much better. So the importance here is that there may be a discordance, and especially in such scenario when patient presents with bony metastasis and lung metastasis not responding to one particular treatment. So there are chances that patient may be hormone expressive, and a hormone treatment may suit the patient better. So my second case is a 66-year-old patient who came with again a breast lump. She underwent surgery, and the lesion was IDC grade 3 PT2N2. EME present, LVI present. This was in 2018. The hormone expression was ER of 85%, PR of 65%, HER2 negative, and Ki67 index of 35%. She was offered surgery, and after that, a standard adjuvant treatment comprising of 12 cycles of paclitaxel, and AC was given till February 2019. And she underwent radiation also till July 2019. Thereafter, she was offered tamoxifen in July 2019. And she developed intolerance to tamoxifen with deranged liver functions. And there was when she was offered exemestane, which she took till February 2021. She continued with hormonal therapy. In October 2021, PET-CT revealed a new lung nodule, and biopsy could not be done at this time. So she was designated as a metastatic breast cancer hormone responsive disease, now with lung metastasis. And the advanced nature of disease, guarded prognosis, and palliative intent of treatment was explained to her. Lab parameters were done, which were normal. So this is the baseline scan, which is normal, and this is the lung metastatic scan, and this is how the patient behaved. And we know that hormone responsive HER2 negative metastatic breast cancer can be a heterogeneous disease. There are multiple disease characteristics that offer a less favorable prognosis. Tumors vary in their metastatic potential and time to metastatic spread. And we have seen that shorter time to recurrence from early stage, that is shorter disease-free interval, liver metastasis, visceral metastasis, lung metastasis, predominantly visceral disease, high tumor grade and a negative PR. All these either alone or together can portend very poor prognosis, and it's difficult to deal with such patients. However, now with the availability of AIs plus CDK4/6 combinations, we have become slightly successful in treating these patients. So there are multiple options which were available a decade earlier. Like chemotherapy was main stay of treatment. Thereafter, it was hormonal therapy, and now we have AIs with CDK inhibitors or a fulvestrant with CDK inhibitor. So this patient was actually offered abemaciclib plus fulvestrant. However, the patient was totally fed up, does not want any prick, so she was offered abemaciclib plus letrozole daily with calcium supplements and denosumab. And we have seen in the previous slides that Monarch 3 study was in a similar setting, and it had shown that the combination of abemaciclib plus NSI offers double PFS of advantage with a significant hazard ratio of 0.54 and a significant p-value. So this is the difference between just a hormonal treatment and a hormonal treatment along with abemaciclib. And we have seen the stratification factors as well, that even though the bone-only disease tends to do better, but with visceral disease patients who are in abemaciclib group, they have a very significant, very low hazard ratio. Similarly, patients who are of any age group or patients who are of negative PR, the hazard ratio was very impressive to the tune of 0.41, which is again very nice to see. So my early clinical experience with this was that patient had grade 1 diarrhea, which started by the end of second week, and it did not require any dose interruption. And this settled over a period of next 2 months. In February 2022, repeat PET was done, and there was significant metabolic resolution, morphological regression of pulmonary nodules, partial response was attained, and no divisions were seen. So this was the lung metastasis, and this was the previous picture, and this is how the patient is doing now. So that would be from my side. Back to Dr. Sachin.
Yeah, thank you, Samit, for presenting your cases. So in the first case, the HER was positive initially, and so this patient did not respond to anti-HER treatment. That's what it appears to be. So that's what prompted you to do a rebiopsy and to find out what's happening, right?
Definitely, yes.
Yeah, maybe the first report was not accurate, or the patient was actually resistant to that.
Maybe
But
yes.
subsequently,
Maybe yes, and we tried to recheck through fish also the second time, so it was negative. So we did a recheck fish also.
And so your second case was a sort of primary resistant, endocrine resistant,
yes.
Because while on adjuvant, within 2 years, this patient progressed. And so this patient had poor prognostic factors as well. Maybe you can go to the next slide, please. So Dr. Samit, let's discuss. So we have now 3 drugs here. And if we look at the hazard ratios in most of these trials, so when we use them with along with, let's say, letrozole or anastrozole, so they are giving us nearly, equal hazard ratio and good PFS this benefits. And but how do you actually pick and choose? So since there is so much of now a lot of options with you, what factors would you consider, and how would you choose a particular drug, let's say abemaciclib versus ribociclib versus palbociclib? So what prompts you to choose one over the others?
So I feel there is a big umbrella to it. There is a big spectrum to it. All metastatic breast cancer patients who are hormone responsive, HER2 negative, can be offered CDK inhibitor along with either anastrozole or fulvestrant, depending on which line setting they are being offered. However, a certain subset of patients, which I would still say would not respond well to the conventional hormonal treatment, like we have discussed in previous slides, patients who have a short disease-free interval, primary resistant patients, patients who come with visceral disease, especially liver and lung metastasis, patients who have very low PR expression, so high-grade histology. So these are such patients who I feel that abemaciclib does have an edge over other two CDK4/6 inhibitors. So that is how I choose my the choice of CDK4/6 inhibitor.
Yeah. So there is some data about single agent activity of abemaciclib as well. So once a multiply treated endocrine, this hormone positive patient is there, and so in the initial the phase, so this was Monarch 1, I think, right?
Monarch 1, yeah.
So they were really still 20% responses. So single agent also had worked. So when abemaciclib was used there. So definitely, if we have a patient who has PR receptor positivity is low and visceral disease is there, and primary resistance. So these are actually the situations where we can definitely choose abemaciclib, and we would have better chances of response for our patients there. And any like the survival benefit data, does that also excites you to use one drug over the other?
Yes, I think that does excite me. However, I think it's still a neck-to-neck, head-to-head comparison between all the three. What excites me, like you said in your previous statement, that single-agent activities there, abemaciclib does have a CNS penetration also. So all these features give it an edge over other two CDK4/6 inhibitors.
Yeah. Next slide, please. So now there is some difference in the usage of these drugs. So palbo and ribociclib. So we use it as 3 weeks on, 1 week off, whereas abemaciclib we are dosing it continuously. And so does that help you in choosing what drugs to begin, and why should we give a drug-free interval? Why should not we give a drug-free interval? And does that impact the response in your view?
So I believe it's based on your T-half, your pharmacokinetics and pharmacodynamics of a drug. Like palbociclib and ribociclib, they have a T-half of just over a day, around 29 hours or 30-35 hours for that matter. So they do achieve optimal dosing, and then you have to give them a break. For 21 days, you give them and then you take 1 week off. For abemaciclib, the T-half is around 18 hours. So our daily dosing schedule is there, and I think it helps in my practice also. I don't have to be too much stringent or too much observation on those patients. Patients can be more compliant, and for that matter, I think I can manage the toxicity as well easily. I can take that drug off if I feel the patient is having too much of a diarrhea or things like that. So I think it would make a patient more compliant.
So yeah, even I in my practice also I've seen. So when we give this drug-free interval with ribociclib and palbociclib, sometimes I have to prolong the interval, and of course decreasing the dose to the next lower level is also common practice here. Abemaciclib's side effect, which is mainly diarrhea, that is quite manageable with this anti-diarrheal agents as well as antispasmodics, and most of these patients actually are able to take the normal proper dose most of the times. And so the continuous dosing also ensures that the anti-tumor activity continues on and on without a break. So that may be actually a deciding factor and a positive factor to pick and choose abemaciclib. And because we don't have to give a break, so that means a better efficacy of the drug, to ensure better efficacy of the drug here. We can go to the next slide. So now a little bit more about toxicities. So Samit, you have used all the drugs, all three. We are quite conversant with these drugs now for last many years of usage. So they have unique toxicities. So some toxicities are common, some are unique to them. So how do you monitor them, and what has been your experience about the toxicities of all these three drugs, and especially abemaciclib? How to handle that?
So I think the toxicities are either symptomatic or asymptomatic toxicities. The symptomatic toxicities with palbociclib and ribociclib are neutropenia, which happens in almost 70-80% of the patients. Almost half of these patients will go to grade 3 and 4. Despite that, it's not problematic. It's fairly manageable. With abemaciclib, we have more of a diarrhea. GI issues are there. Nausea, vomiting is more. Again, with ribociclib, you need to take care of the QTc interval. So a regular ECG monitoring is required. And other than that, I think asymptomatic transaminitis is again seen with ribociclib. With abemaciclib, again, the rise of creatinine is one such issue, even though it's not problematic, but again, it can be seen on the paper. So all these toxicities are there. And what I try to monitor in these patients is I do every fortnightly CBC, LFT, and with ribociclib, I take into account doing ECG as well. So that is how I do it for at least 1 or 2 months, every fortnightly, and then I do it every monthly.
Yeah, so this QTc prolongation is actually a matter I have also seen in one of my patients. So wherever there are some cardiac issues and hepatic issues, so we tend to avoid ribociclib there. There is some data about slight increased risk of venous thromboembolism with abemaciclib. And although I've not seen it and not encountered it personally, but the literature does say that, so we have to be little careful about that. And otherwise, majority of times these are quite well manageable.
I have lost
yeah,
one
you were saying
patient
something?
because of unfortunately I lost one of my patients because of this thrombotic event. Patient was on ribociclib.
But of course, all majority of this metastatic carcinomas, adenocarcinomas, they are otherwise also predisposed to having thromboembolic events. So the multiple factors are working there. And of course, we have to individualize toxicities and choose the best drug for our patients in those situations. Next slide, please. So now, so we have discussed this particular point regarding the visceral metastasis and this visceral crisis thing. So we do pick and choose CDK4/6 inhibitors plus, let's say, letrozole or fulvestrant in majority of the time. So we are doing this already. Now, does this, let's say there are multiple lung metastases or patient is presenting with liver disease and LFTs are deranged versus not deranged, breathlessness versus no breathlessness, would you use CDK4/6 inhibitors upfront still even in patients who are challenged or have some symptoms, or would you say choose, let's say, weekly chemotherapy or something like that?
So if I have a symptomatic disease, if I have a visceral medicine not compromising the viscera, so I can start with my CDK4/6 inhibitor. Or if I feel that patient is going into a visceral crisis, the biochemistry is deranged and patient is too much symptomatic, I would start with chemotherapy.
So in my experience also, but I have used upfront, let's say, abemaciclib or ribociclib in patients who have been challenged, who have symptomatic as well, because there the usage of chemotherapy also is very difficult. So rather, I have found that since these drugs give us a good tumor shrinkage, which is as good as what we can expect with chemotherapy, in majority of times we are able to use this upfront. So wherever visceral disease and even extensive visceral metastases are there. But of course, we have to, go to chemotherapy if we feel that patient is, let's say, not responding, or there are parameters which are worsening while we are, starting on CDK4/6 inhibitors.
So I think it's the rapidity of response what we want. So
yeah,
I think it's the rapidity of response what we are looking for in such patients. If the patient has a declining organ function, chemotherapy may be the right way forward. Otherwise, CDK4/6 inhibitors have shown that they do act fast also. So they are.
The clinician has to judge how much the patient time he is giving us and how fast the disease is responding or progressing there. Yeah, that's fine. Next slide. So this was about the visceral crisis. And so we have already discussed this. So in majority of situations, we would be able to start these drugs upfront, but wherever we feel that patient is deteriorating and may not give us enough time to respond, then of course we have to, choose chemotherapy first or switch to chemotherapy wherever required. So thank you, Dr. Samit. I think we are right on time, and your inputs were very relevant and valid for this discussion. And so we end this session here. And Surbi,
Thank you,
we
Dr.
can
Sachin. Thank you for
thank you, Dr. Samit.
So Dr. Chandora will join by 8 o'clock. So we'll invite Dr. Aparna ma'am.
Yes, he was busy with another session also. So we can do the next session, which is by Dr. Aparna Thar, who is HOD Medical Genomics and Genetic Counseling at SRL Limited. And so Dr. will be enlightening us on diagnostics in breast cancer and where are we in 2022. As clinicians, we are closely working with our diagnostic facility, doctors, pathologists, and so many new information is coming that it has become hard to actually keep pace with it. And so this session was highly required and relevant, and we have a very right person to do justice to this. So Dr. Aparna, please.
Hi, good evening, everyone. Thank you, Dr. Sachin, for the kind invitation and organizers for having me here today. So I've been given the task, this is a rather long-winded title, but essentially to walk you through the molecular testing landscape, especially in breast cancer. So before we even start talking about this, let's first understand why is molecular profiling important in breast cancer, right? Actually, just in general, when we talk about molecular profiling, there are a couple of reasons, oops, sorry, my slides are acting funny. So one is that, the tumors, we know that tumors can have different profiles, they require different therapies. One target could treat multiple tumors, like your agnostic markers. We've learned one target, one drug will actually eventually lead to a resistance. One target, one drug really does not inform you of more potent targets. And one target, one drug really does not give you the entire picture. So when we want to talk about, diagnostic testing in breast cancer, and the molecular landscape, first just understand the tumor biology. It always comes down to the basics, right? So breast cancer patients are classified as per the ER/PR HER2 status. The triple negative breast cancer subtype constitutes for around 15% of our patients with treatment options for chemotherapy. Then you've got your hormone receptor positive disease, which constitutes for around 70% of our patients. And we know hormone therapy is the mainstay of treatment. And then there's around 15%, which are HER2 positive, where the anti-HER2 therapy improves significantly the prognostic outcome in both early and advanced settings. But if you think about it, we've actually moved beyond this very intrinsic subtypes as your HER2 positives, your luminal A's, your basal-like subtypes. You're actually looking for more genomic drivers. You've gone beyond those simple classifications. You're looking at alterations in the PIK3CA pathway. You're looking at mutations in the DNA damage repair pathway, which is essentially your Bracha genes. We're looking at resistance mechanisms in the ER signaling pathway, growth factor receptors like FGFR1, which could potentially allow us, to have more targets that allows us to personalize treatment strategies in patients with breast cancer. And this is becoming even more important for our patients with, this is becoming, especially for our metastatic patients. So, if you look at the molecular landscape of this breast cancer metastatic disease, it's very heterogeneous. And you can see from this slide that with each of the subtypes, the HR positive, the triple negative, you have a plethora of different somatic mutations that can occur. And if you want to look at the differences between our early and our metastatic, you see there were at least 9 driver mutations, your TP53, your ESR1, you've got your AKT, and more frequent, these were more frequently mutated in your ER positive metastatic breast cancer versus early. Then you've got your metastatic triple negative, which showed an increase in the frequency of the somatic loss of function in mutations that when you're homologous, that basically perform homologous recombination repair. This is like your BRCA1, BRCA2, which are in the DNA damage repair pathway. And then your metastatic breast cancer patients showed an increase in the mutation burden and clonal diversity as compared to early breast cancer. Now, sorry, the poster child for building molecular profiling treatment algorithms and just the diagnostic testing has always been lung cancer. So what about breast cancer? And again, this is a very simplistic view of patients with breast cancer. And this flowchart actually alludes to the fact that one, you have only 3 biomarkers, ER, PR, HER2, but it also assumes that these biomarkers stay static. And we know that when a patient's tumor recurs or when a patient has stage 4 de novo on progression, these biomarkers are not static, and about 30% of patients with ER, PR, HER2 could have a loss or gain of function. The third thing is it also assumes that there's only one pathway that is dominant, which again, I'm going to show you that you really need to see different pathways that are activated when it comes to treating our patients. So this is a very simplistic, a very, very simplistic view of patients with with metastatic triple negative breast cancer. And we know chemo treatment options is your option of choice. As you can see, the PFS decreases with each line of treatment. So if you look at the tumor biology of triple negative breast cancer patients, we know that they're typically associated with the worst prognostic outcome. And you can see from this heat map over here that patients with triple negative breast cancer, it's not as simple as we think it is, right? So even amongst these group of patients, we see subtypes like luminal AR, mesenchymal, basal immune suppressed, basal immune activated. And among each of the subtypes, we have different treatment strategies. Like you've got immunotherapy for your, what's this called? Basal immune activated subtype. You've got PARP inhibitors for those, with alterations in the DNA damage repair pathway. And then you have your immunotherapy combinations in your basal immune suppressed subtype. And of course, then you've got this anti-androgen therapy in your luminal AR. So it's not a very simplistic view. So this is what I personally think should be the optimal molecular diagnostic algorithm for our patients with metastatic triple negative breast cancer. And you can target the defects in the DNA damage repair pathway, where we know PARP, platinum therapy have very clear roles. You could target the inflamed phenotype where immunotherapy, again, has a very clear role. We've got our SP142 clone in PD-L1, you've got your TMB, and obviously your MSI testing. Then we've got the androgen, the AR pathway. If it's positive, we have a mutation. Then we've got alterations in our PI3K pathway, where we have AKT inhibitors. And last but definitely not the least, we've got those agnostic markers like your NTRK fusions. We've got RET, which has an orphan drug status. And this is a forever evolving algorithm. And I think this is where we are today in 2022, but there's so much more data. For example, EGFR T790M, in our triple negative breast cancers, we are seeing these mutations. There are a lot of clinical studies where maybe osimertinib, again, maybe it's early phases in clinical trials. So there's a lot of data coming, and this is forever evolving. So what I'm going to do is I'm just very quickly going to walk you through the data I have used to build this algorithm. We're very familiar with the Impassion 130 trials for triple negative breast cancer patients, and it's illustrated that the PD-L1 positive cohort had an improvement in the overall survival, as very beautifully depicted in these Kaplan-Meier curves. Then triple negative breast cancer patients with germline BRCA mutation, which means you've done NGS. If NGS was negative, as you reflect, you've done MLPA for those large deletion duplications. And we've got this data from the Olympiad and the Bracha trials that alluded to the fact that if you have mutation in this biomarker and PARP inhibitor was given, you saw a very nice separation in the Kaplan-Meier curves that was favoring the group of patients who received a PARP inhibitor. And this was very interesting data from a phase 2 trial where triple negative breast cancer patients received a combination of chemotherapy in the form of it was paclitaxel and capivasertib, and capivasertib is a target for the PI3K pathway. It is an AKT inhibitor. And what you see is a very nice separation in these Kaplan-Meier curves, favoring the patients who were getting a combination versus those tumors that did not have an alteration in their pathway. Now we move on to looking at the molecular diagnostic algorithm for the HR positive, which means the ER/PR positive HER2 negative subtype. And these patients not only have ER/PR as potential biomarkers, but you also need to look at different pathways, such as those, where they can acquire an ESR1 mutation. And because we know if they have an ESR mutation, we know agents such as aromatase inhibitors do not work very well. And you need to look at agents such as fulvestrant. And again, in the HR positive, we see a defect in the DNA damage repair pathway. PARP inhibitors can work. We get this from our Olympia trials for our that means your patient has a germline BRCA mutation. We also look into the AKT pathway, and then you've got those agnostic markers. Now, for me, the HR positive, your hormone receptor positive cohort, I think the tumor biology of this disease, it should be the new norm, that when you get a patient upfront, we do molecular profiling. And the reason being is these patients do acquire that endocrine resistance, they do acquire an endocrine resistance, and you can see this in this very nice animation over here that where, with patients who have an endocrine resistance are endocrine sensitive, and the tumors have very small clones of ESR1 mutation. You give them hormonal therapy, about 18% will acquire an ESR1 mutation, around 13% will have a defect in the MAP kinase pathway, and around 9% of acquired mutations in the MYC pathway. And these acquired genomic alterations eventually result in endocrine resistance. And another very important thing when we're looking at this HR positive is that, and I want to point out, is that these targets, they're not static, they're not just there. They're not just there on their own. They're kind of interconnected in this very tight mesh of signaling molecules in sort of a very simplified version. I like depicting it in this triangle that emphasizes the three most important nodes in the signaling network. On one hand, you have the estrogen receptor, ER. On the other hand, you've got your CDK4/6. And then up there, you've got your PI3K kinase pathway. And whatever you do, the ER-positive breast cancer, the ER-positive breast cancer with any of these angles, with any of these signaling nodes in this triangle, if you look after one angle, the other two get activated. So if you try to, let's say, block ER, the PI3K and the CDK4/6 act up, and if you block PI3K on its own, the ER signaling goes up. And this is why we do not give PI3K kinase inhibitors as a single agent, and because you have this adoptive increase in the other components of this triangle. And this triangle actually also shows you the new age of clinical trials now after developing various doublets, whether it's endocrine therapy and CDK inhibitors, or if it's a hormonal therapy, PI3K, with PI3K of the mTOR pathway. And there's a new wave of clinical trials that's actually focused on developing regimens that at the same time targets all three angles. And there are a series of trials that we'll see, within this triplets that are coming up with far better outcomes than, let's say, what we were having with our doublets. Now, some somatic mutations do differ between early and late in metastatic breast cancer, especially for our ER-positive subtype. And this is one of the things that's been very interesting in the last couple of years, is the identification and development of tumors acquiring alphabet signatures in high TMB, and this could be a potential biomarker. And this was a very nice study that was presented at ASCO in 2018, and this patient initially had an ER-positive breast cancer in 2001, had the appropriate treatment for early stage breast cancer, and eventually, there was a recurrence in 2010, and then you can see that eventually after multiple lines of therapy, in 2015, an APOBEC high signature was found, and she was, essentially treated with a combination of pembrolizumab and chemotherapy, and the patient did respond. So there's a lot of interesting work happening over here, and maybe this could be a potential biomarker going forward. The SOLO-1 trials, we're all very familiar with this. In a cohort of patients with PIK3CA mutations were treated with a combination of fulvestrant and alpelisib, which is a PIK3CA inhibitor, and he saw a very good response. And what was interesting over here from a diagnostic purpose was that it really did not make a difference if you pick this mutation on tumor testing or liquid biopsy. Interestingly enough, liquid biopsy having a far higher sensitivity, we're able to call out these resistance mutations, these PIK3CA mutations, far quicker and earlier than tumor testing. Now, I've said this before, you can acquire a HER2 mutation, none of these are static. And over time, we've seen this more so in our patients, with HR-positive breast cancer. So this was the phase 2 SUMMIT trial that looks at patients with pure HR-positive, HER2 mutant breast cancer and gave them a combination of niraparib and fulvestrant, and these were, again, very heavily pretreated patients. And the combination did result in a clinical benefit rate of around 47% and a PFS of around 5.4 months. And looking at all of this, I think this is how we treat our HR positive, HER2 negative breast cancer. And I think this is a more personalized approach, with our CDK4/6 inhibitors, our aromatase inhibitor, with aromatase. And eventually we know that there is going to be there is going to be resistance. So then we do a PIK3CA testing, if not ESR1, at least PIK3CA. If your patient is positive or negative, irrespective, we have therapy options. When a patient progresses, again, there are more testing options that are available. So this is, I think, where we are in testing with our HR positive. Now, the flavor of the season is always PARP inhibitors. I hear it everywhere. So I very quickly want to draw your attention to a very important concept called the Bracha reversion. And this is especially in our heavily pretreated patients, be it your breast, ovarian, pancreatic, or prostate. So Bracha reversion is essentially a phenomenon whereby the BRCA alterations have the potential to restore their reading frames and revert to a wild type sequence, or kind of remove that initial deleterious alteration and restore at least partial BRCA function. And especially our BRCA2 is more susceptible to this. This was a fantastic case study to demonstrate this concept of a patient with this was a breast cancer ER positive patient, multiple lines of therapy. They did testing. She came positive for a germline BRCA mutation, a BRCA2. She was treated with a PARP inhibitor. She had a PFS of around 8 months. She progressed out of chemotherapy. She continued to progress. They did a liquid biopsy, which confirmed that this was, it was a BRCA reversion. So we know that ESMO has actually come out with a scale of clinical actionability of molecular targets, especially in breast cancer. And you can see the level 1, level 2 incident evidence, tends to be in terms of looking at, what we normally do in our clinic. Your HER2 amplifications, your germline BRCA testing, your PIK3CA, MSI, NTRK, ESR1, PTEN loss, AKT mutations. And in addition to that, we also have a plethora of some other targets which will have less evidence, but it also, less evidence that supports it, but we still look at them as there are clinical trials that are investigating into it. Now, with breast cancer, we know that it is, especially metastatic, it is a very heterogeneous disease, especially, be it both inter and intratumoral. It does cause a problem when you're trying to trace those biomarkers in your patients. And one way to really be able to look at the genomic landscape for me, I think, is a liquid biopsy. And you're essentially looking at the circulating tumor DNA, which is, the somatic, the tumor DNA, which is discarded into the bloodstream. You isolate it, and then it undergoes molecular profiling. So CTC, circulating tumor cell, is, your intact cells that are in the bloodstream. And due to paucity of time, I'm not going to be talking much about them, but there's some fantastic work happening in CTCs from a survey, from a screening management perspective, especially for breast cancer. So how do we use liquid biopsy in our clinic, in our metastatic breast cancer patients? Well, it actually helps us detect 2 types of resistance mechanisms. The first one, which is linear clonal evolution. And what you're doing here is that it evolves tumor cells where you have a temporal evolution where one dominant clone, you lose the dominant clone, and one of the less dominant clone now becomes dominant over time, which is selected out by therapies. The second one is what we call branch clonal evolution, where you have spatial evolution in terms of divergence of different clones that happens, and what you essentially get is a mixture of different cancer cells resulting in a mutation. And like I said, liquid biopsies, there are various aspects, that we can use in clinical practice. But I think today I'm just going to stick to the metastatic disease, where it helps us, it helps in addressing the issue of tumor profiling, monitoring treatment response, monitoring resistance response, and most important of all, addressing the issue of tumor heterogeneity. So one of the questions, that we do tend to ask ourselves when our patients walk in is the clinical utility. What are the benefits we're looking at when we are profiling our patients, and especially metastatic? Why are we so clear? Why am I, for example, saying circulating tumor DNA might be a better option in, for monitoring our patients, for actually doing the, for doing the molecular profiling in our metastatic patients, versus just, kind of doing the tumor profiling, from the primary part. And this was one of the questions that even the MIRROR study asked. And what they evaluated was, one, the concordance of genomic variants between the primary tumor tissue and ctDNA in patients with metastatic breast cancers. And here's what they found out. So there were around a 97% concordance between, the primary metastatic tumors, and the same was also detected in our circulating tumor DNA. But interestingly, the metastatic tissue and ctDNA didn't, some 13 variants that were not present in the primary tumor, because we know the tumor is heterogeneous, and circulating tumor DNA was used to detect these genomic alterations, and they did a fantastic job. So circulating tumor DNA liquid biopsy was not inferior to tumor biopsy. Was not inferior to tumor testing. And again, SCBCS, we had the plasma map study in 2019. I think one of the most fantastic studies, in the realm of metastatic breast cancer, especially, using liquid biopsy. So while I'm not going to be talking much about the study design, for me, what was a very important thing in this particular study was that they compared the sensitivity of liquid biopsy with paired tissue testing. And, a sensitivity as high as 93% is pretty decent. And what they did is that they further cemented the fact that liquid biopsy could be used to call out and track those resistance mutations. And then they went and further, what they did is they did a liquid biopsy NGS versus ddPCR. And NGS had a propensity for pulling out more mutations versus ddPCR. So I thought from a molecular diagnostic perspective, and I'm not going to the clinical aspect of plasma match, this was a fantastic study. So how do we use these? How do we use liquid biopsy to identify these drivers in our clinic? I think this paper that was presented by Dr. Chandra Pati from the Memorial Sloan Kettering group, I think it was beautifully presented. This was a case of an ER-positive patient, ER-positive invasive ductal carcinoma, and let's just look at the ESR1, which we know is a common resistance mutation. And tumor testing in Feb 2015 did not identify it. However, when they did plasma testing, when they did ctDNA testing, that was where we had only detected this early in Feb. In tumor, they were able to detect this only in July. So liquid biopsy does have its pros. Now, early on, I showed you results from the SOLO-1 trials where patients with PIK3CA mutations were treated with fulvestrant and alpelisib, and they had a really good PFS. So the real question there was, are there other markers within this group of patients that could allow you to tease out those who would or wouldn't respond to alpelisib? And this was a very nice paper that came out in 2020 in Nature Cancer that looked at alterations in the PTEN and the ESR1 that could potentially promote clinical resistance to a combination of alpelisib, with with fulvestrant. And what the author showed was that at baseline, if you sequence a tumor of your patient, you would not really see a clinical benefit. And if there was a PTEN or an ESR mutation, you don't always acquire it right at the baseline of the tissue, but you could acquire it over time. And they use ctDNA pre and post to actually call these mutations out. And what they saw was that the presence of an ESR1 and PTEN mutation could actually indicate resistance to a combination of anti-estrogen with a PI3K kinase inhibitor. And again, liquid biopsy had a far more higher rate of matching our patient's tumor versus tissue testing. So it just showed that in metastatic disease, it might sometimes be helpful that I know tissue is the gold standard. If you don't find a mutation on tissue, it might be helpful if the patient is affording, and you don't have to send it for one of these expensive tests to the US, but even our in-house tests that our domestic labs or service providers are giving, would be a good idea that if your tissue is negative, you haven't found something helpful for your patient, as a reflex, think of doing a liquid biopsy, not a big panel, at least a 10-15 gene panel specifically for breast. And for the next 5-7 minutes, very quickly to close this, we're talking about germline testing. And for me,
we have to conclude now.
Oh, okay.
Now some couple of good questions so that.
Okay, so let's just go to the last one, which is very, very simple, which is, I do think that when we talk about liquid biopsy, when we are, talking about this particular subtype of patients, I think tumor biology is very, very helpful to guide treatment. While ER/PR HER2 is important, let's look at those other genes to help guide treatment. If tissue is an issue, I think liquid biopsy can be a good option. And when you're doing germline testing, while I couldn't spend much time on it, do think about sending it to a geneticist to help and ensure that your patient gets the right germline test. And on that note, thank you very much for your patience listening.
Thank you, Dr. Aparna. So quickly, so do you think this this germline testing, hereditary germline testing, should be done for every breast cancer patient?
I'm not in favor of doing it for every breast cancer patient unless it's a triple negative. Otherwise, I'd like to stick to our guidelines as of today, which says anybody, under the age of 50 who's been diagnosed under, or or even 60. With the Indian population, I tend to use 60, or has a strong family history where we see male breast cancer, pancreatic cancer, prostate cancer, ovarian cancer, or just something very unique and rare within the family. In those cases, yes, then I do recommend germline testing. The only time we can maybe do it in the ER positive and HER2 negative subtype, irrespective of age, if you're looking for a therapeutic perspective. Otherwise, I'm pretty comfortable at this point.
And do you see this role of ctDNA in near future, at least, for recognizing early recurrences? You know, after having done adjuvant treatment and all. So will that see light of day in coming years?
I'm an optimist. I'm a forever optimist, but I think CTC, circulating tumor cells, is there are some very interesting trials that are happening, not internationally, but even in India, you know, with certain service providers, where we're seeing brilliant data in actually calling out and identifying early recurrence even before the disease presents, or we can radiologically trace it. So there is a lot of good work happening there, and I'm very hopeful in the next maybe 18 months, we could be bringing it into our clinical practice.
Actually, that is going to complicate a lot of things for the clinicians and the patients. You know, we have this technology now. What is happening is that diagnostics are way ahead of therapeutics. We have targets, we don't know what to do with them. We have, you know, you guys give us reports of NGS where the tumor is different, the mutation is of some other tumor, and the drug is of some, you know, of altogether a different area, and which is not even available to us. And to top it with the, you know, the variability of the types and the ways you do PDL1, we are, you know, lost a lot of times what to do with PDL1.
That's true.
And so the thing, so that's why we need your help and your you know, inputs a lot of times to guide us how to use this test judiciously, so that not to complicate things at least. But we do end up, you know, getting this test done, and we don't know what to do with the report actually.
Yes. No, it's unfortunately it's very exactly, it does become very complicated, and I'm not even embarrassed to say it becomes complicated for us sometimes, because every lab has a very different style of reporting, formats. So I think in cases like this, if we all work together, I think tumor boards, interactions, or just one-on-one discussions that look, and this is what we do in our practice is, and I know the testing goes to every other diagnostic, everybody's got their own preferred service provider, but I think talking, interacting, having conversations, exchange of information not only helps us learn from you and understand the challenges in your clinic, but also kind of helps us help ensure that the right test is done. Because sometimes, you know, like I always give the example of triple negative breast cancer, that forget germline testing, forget molecular profiling. Have you done a basic IHC-AR? Like, if that's positive, you've got a straightforward drug therapy, which is available in India, you know? So I think conversations and just open dialogue between different disciplines will help, and we're all learning and we're all growing, you know, with this whole precision medicine revolution.
Thank you, madam. Thank you for all your presentation, as well as answering our questions and for your inputs.
Thank you for having me. Thank you.
Move on to the next session. So Dr. Shefali is with us now. So Shefali is a fellow colleague at, she's a senior consultant in medical oncologist at Max Hospital in Delhi. And so now I put this topic deliberately because this is again a difficult area. How do I manage multiply treated triple negative breast cancer? So most of us are, you know, getting stuck with Tnbc. Once it's metastatic, once it's relapsing after having used 2, 3, 4 lines of treatment. And we have a lot of young patients actually who give us enough time and, you know, continuous efforts to actually treat them. So I hope Dr. Shefali does justice to this session. Over to you, madam.
Good evening, and thank you, Dr. Sachin, for giving me this opportunity. Are my slides visible?
My photograph on your slides.
Sorry, I could not hear you. Are my slides visible to everyone?
Yes, ma'am.
All right. Okay. So thank you. And to address your question, I'll try to do whatever justification I can do with this subset, the metastatic Tnbc, which is multiple lines treated. So I have not intentionally, categorically put up slide for per se investigations, what needs to be done in this subset. I'll be highlighting as I move down my slides. So as we all know, in India, triple negative breast cancer actually constitutes 30% of all invasive cancers, and incidence of triple negative breast cancer we know is higher in patients who are younger, less than 35, and are premenopausal. Globally, also Tnbc accounts for 10 to 20% of all breast cancers, and majority of Tnbc tumors are basal-like or claudin low. So when we talk of tumors, when we talk of tumor which are claudin low, that means their gene expression is heterogeneous. So given the lack of effective treatments in this subtype of breast cancer, several efforts have been conducted in recent years to increase the therapeutic options and opportunities for TNBC. And we all know the survival of TNBC drops drastically as we move on stage by stage, and when the progression is there even in the advanced stage. And higher proportion of TNBC present actually in locally advanced stage to diagnose with, and they are more positive as compared to other non-TNBC counterparts. Now, when we see the profile of triple negative patients in India, they are more diagnosed in stage 2 or stage 3, and they are younger age group. They have aggressive grade 3 disease as compared to the non-TNBC stage by stage. So, how can we improve survival of TNBC patients in such subgroups, and what are the clinical evidences? So if we move down the line in metastatic TNBCs, somewhere in the metastatic setting, the role of carboplatin due to BRCA-NES or BRCA mutated subgroup was highlighted, which subsequently moved above in the stream to neoadjuvant setting. So this TNT trial actually assessed the efficacy of carboplatin and its role as compared to taxane in phase 3 trial advanced TNBC. A pre-specified protocol enabled biomarker treatment interaction also, and to investigate or to say whether we should test germline BRCA positivity in this subset, whether this makes any difference in this setting. And the primary endpoint was objective response rate. So this trial showed that in subjects with germline BRCA mutated breast cancer basal type, actually carboplatin had double the overall response rate of docetaxel. That was 68% versus 33% respectively. And it was according to biomarker treatment interaction, the p-value was significant. However, such benefit was not observed for subjects with BRCA methylation or BRCA mRNA low tumors or a high score in myriad HRD assay. So to having said that, HRD score would not lead to prediction of the responses to carboplatin. But however, in this subgroup of BRCA mutated or BRCA-NES, carboplatin actually doubled the overall response rate. Now, this conclusion we already discussed. Gene expression analysis. So this is the investigation which we should do in advanced TNBC. So gene expression analysis of these cancer may influence the treatment selection. Now, similarly, Olympiad. We know Olympia in the adjuvant setting, in inclusion of olaparib has made a IDFS difference. And now Olympiad, similarly in the advanced setting, patients with HER2 negative MBC who had germline deleterious BRCA mutation and TNBC or hormone positive, less than equal to 2 prior lines of treatment, they were randomized to olaparib versus standard of care chemotherapy, and which was continued until progressive disease or tolerability in terms of toxicity. The primary endpoint was PFS. Secondary endpoints were time to second progression or death or overall survival. Now, if you see the graph, olaparib actually improved the PFS, median PFS, 7 months in the olaparib arm versus 4.2 in the chemotherapy standard of choice, and p-value was significant. So similarly, again, one more trial which tried to test olaparib monotherapy in metastatic breast cancer patients who were germline or somatic mutations, and the cohort was expanded to HR pathway genes also. So this was olaparib expanded trial. We all know that background of this rationale was the identification and expression of this BRCA mutation, more subset in TNBC, and whose breast cancer have HR deficiency, and they may benefit from therapies like PARP inhibitors. So this olaparib expanded study had a hypothesis that olaparib will have an overall response rate of more than 20% in breast cancer patient with a germline or somatic mutation in the DNA damage response pathway genes. So I'll not go into more eligibility criteria, but they were more than 2 chemotherapy regimens progress. So that is heavily pre-treated metastatic TNBC setting, basically. And germline or somatic were included, and according to HRD score, they were also included. So this trial also concluded that in this proof of principle study, the primary endpoint was met in both of the cohorts, but responsive to olaparib were specific to somatic BRCA mutation, where overall response rate was 50%, and germline PALB2 mutation, where overall response rate was 82%. And however, no responses were observed with ATM or CHEK2 mutations, and responses in all breast cancer subtypes were observed. So now, similarly, in this Abrazo phase 2 study, which studied talazoparib in similar cohort of patients, also extrapolated the similar results, that addition of this kind of PARP inhibitor actually improved overall response rates in advanced multiple lines treated TNBC setting. Now, having said that, apart from olaparib, we need to also see the role of eribulin in this kind of heavily pretreated MBC. We cannot underestimate the role of chemotherapy once all these targeted or novel agents are coming up. So in this EMBRACE phase 3 trial, women with locally recurrent or metastatic breast cancer, and highlight important thing is 2 to 5 prior chemotherapy regimens progression, post 2 to 5 prior chemotherapy lines, and less than 6 months of most of recent chemotherapy used. And actually, this is the real world trial, which included the neuropathy grade less than equal to 2 patients also. So subsequently, down the line, so much of heavily pretreated, the patients also have side effects or toxicities by this time. So they were randomized to eribulin versus treatment of physician choice. Treatment of physician choice included any kind of chemotherapy which they can use in this line setting, and also the local radiotherapy for symptomatic relief. And this thing was continued until progressive disease or unacceptable toxicity, or it was dependent upon physician and patient consent to continue. The primary endpoint was overall survival. Secondary endpoints were PFS and overall response rate. And as you can see with this forest plot, that most of the trend, and especially the TNBC highlighted group, favored the eribulin cohort versus the treatment of physician choice. So having said that, eribulin has worked fairly well in the real world scenario also in our heavily metastatic, in heavily pretreated metastatic TNBC setting. And it also gives overall survival advantage of 2.4 months versus control. And PFS was 4 versus 3.4 months in favor of eribulin. And mind you that it was an intention to treat analysis. So doing an intention to treat analysis in such heavily treated subset is again a challenge. So randomized, and this is again one more trial which compared eribulin versus paclitaxel as first or second line therapy for locally recurrent or metastatic breast cancer cohort. And this trial actually concluded that clinical outcomes were equivalent, whether we use eribulin or paclitaxel in the first or second line treatment in advanced breast cancer. And eribulin may be a suitable treatment option in this setting. Now, after chemotherapy, can we refine or redefine the use of immunotherapy in this advanced subset? So to highlight, there are a few trials which look into this setting, and to mention some of them are Keynote 119 and Enhance 1 trial and Encore 602 trial. So what is the rationale behind checkpoint inhibition in this subset is, we know that TNBC have more tumor infiltrating lymphocytes, they have a higher PD-L1 expression, and they have a high tumor mutational burden. So we know that immunotherapy works on these principles somehow, but however, they are not the very defined biomarkers for use of immune checkpoint inhibitors. And as we can see in this slide, that be it pembrolizumab or atezolizumab, we know that first line setting has a good response rate, better advantage with the use of immune checkpoint inhibitor, and we have now seen their advantage in neoadjuvant setting also. However, we cannot underscore their role in the advanced setting. So still in the advanced setting, people can see a very good response or in the terms of very good PR and even CR in this setting. So now, I mean, we can see that when atezolizumab and pembrolizumab monotherapy was used in advanced TNBC more than equal to 2 lines of pre-treatment, the CR and PR achieved were also wonderful in this setting. So immune checkpoint inhibitor have definitely a role to play in advanced heavily pretreated TNBC. However, in this setting, because we do not have predefined biomarkers, we do not have a measurable criteria to define the advantage because they are already pre-treated. Some of the toxicities are there down the line. So the role in measurable terms needs to be redefined actually. So coming to Keynote-11 trial, so this trial actually recruited 1 to 2 prior systemic treatments, pre-treated metastatic TNBC, and they had a document disease progression on most recent therapy. However, the performance status was still 0 to 1. But in real world scenario, I mean, we hardly find post multiple lines treated PS 0 to 1. So that does not mean that we cannot extrapolate its use in PS2 patients. We know that immuno can be safely done there. So what they did was they randomized in 1:1 fashion to pembro versus investigator choice of chemotherapy, and which included either capecitabine, eribulin, gemcitabine, or vinorelbine. And they were followed up for safety analysis and survival every 3 months. So this trial concluded and saw that there was no significant difference in OS between the arms when they compared CPS more than equal to 1 or more than equal to 10. However, in a subset analysis, trend to improvement in efficacy for pembro was seen where CPS was more than equal to 20%. So what can we derive out of it is, though the CPS or PD-L1 testing is not an absolute biomarker for use of pembrolizumab in this setting, however, higher the CPS, higher the PD-L1 expression, this gives us a little confidence to use this type of treatment in heavily pretreated metastatic setting where we do not have much of the choices to make. And this trial also tried to see the association of TMB and clinical outcomes by treatment, and it showed that trend to improvement in overall response rate and overall survival was seen where TMB was more than 10 mutation per megabase. So again, TMB not an established standard of care biomarker, but having said that, this kind of finding or testing of tumor mutation burden in this cohort may lead us to a confidence to use this treatment in heavily pretreated metastatic TNBC. Now, how can we see the enriching biomarkers for monotherapy responders are? So higher level of TIL infiltration, more the PD-L1 expression and more the expression of TNB like we saw actually give us the confidence. So now this was enhanced one. Again, a phase 1B or 2 study of eribulin plus pembrolizumab in metastatic triple negative breast cancer. So they saw the results in 2 types of strata. One is who received 0 prior line of treatment or 1 to 2 prior line. And they tried to categorize the results in PD-L1 positive versus PD-L1 negative. And they saw that median PFS in PD-L1 positive was 6.1 months as compared to say 3.5 months in PD-L1 negative, and overall response rate was again 34.5 in the eribulin plus pembro arm versus the control arm versus 16.1% in the control arm, and it actually saw numerical overall survival advantage also. In similar results were seen actually not in the numerical terms but in the PFS terms in terms of the pre-treated patients. So now again, one more study which saw a phase 2 trial of atezo plus etinostat. Now etinostat is a HDAC inhibitor which actually works in the apoptotic pathway. So they combine, I mean, they use both atezo and etinostat in advanced triple negative breast cancer who were post 1 to 2 lines of prior systemic therapy. And they randomized into the experimental arm of immuno plus etinostat versus immuno alone. And this was to be continued till progressive disease or the patient withdrawal from the trial. And however, this trial concluded that etinostat addition did not make a meaningful difference in the PFS or the response rate terms. So to summarize these IO trials, we know that there are certain biomarkers of response which can give us a value of confidence to use immune checkpoint inhibitors. However, they have still not been proven as standard of care to make a decision to use these drugs. And we know that chemo plus immunotherapy is standard of care in metastatic TNBC for PD-L1 positive. In the ATIZO trial also, we saw that results were more skewed where the expression was more than 10%. However, the drug is approved in all cohorts in the intention to treat analysis. And the novel combination strategies, be it the HDAC inhibitor plus ICI or MEK, AKT and PARP inhibitors, they still need some more clarity in terms of trial in this setting. Now, coming to antibody drug conjugate.
Summarize and conclude.
Yeah, sure. This is the absolutely last 2-3 slides. So just to mention sacituzumab govitecan, it's antibody drug conjugate which uses SN38 as the payload of choice. We know that heavily pre-treated Destiny trial, Ascent study, and Ascent study also, this tested sacituzumab govitecan versus traditional chemotherapy in heavily pre-treated metastatic TNBC, and it showed that median PFS for patients in this experimental arm was 5.6 months as compared to 1.7 months in the chemotherapy arm, so which was statistically significant. So this is also one of the choices where we have heavily pretreated metastatic cohort. Now, there is something which is newly coming up now as a HER2-low breast cancer. Now, HER2-low can be hormone positive or HER2-low can be hormone negative. HER2-low means where the HER2 expression by IHC is either 1+ or 2+. It cannot be 3+ or 0. So in this subset also, the Destiny trial, which tested trastuzumab deruxtecan versus physician choice of chemotherapy in heavily pre-treated either hormone positive or hormone negative breast cancer, it also showed that trastuzumab deruxtecan did a meaningful improvement in PFS. And these are the other studies which are testing trastuzumab deruxtecan and other antibody drug conjugate in this multiply treated, heavily pre-treated TNBC cohort as well as the hormone positive cohort. So again, one more ADC that is testing dapirolizumab deruxtecan in the Tropion trial, and one more ladiratumab vedotin, again antibody drug conjugate. So to conclude, my take-home message is heavily pre-treated metastatic TNBC, though, is a challenge to treat. However, with the advent of these novel molecules, we still have something in our armamentarium which can make a meaningful difference. Thank you.
Thank you so much, Dr. Shefali. So it is indeed a difficult scenario once we have patient who has undergone multiple lines of treatment. So what to do next? So we have a lot of investigations you can do, and we do have, all of us have patients where we have used immunotherapy, we have used PARP inhibitors, and we have got good responses, but a lot more to be done. It's still a challenging disease to treat. So next we have thank you, Dr. Shefali. So we move on, and I'll request you to stay with us for this next very exciting panel by Dr. Manish Singhal. So Manish is discussing with us sequencing of anti-HER2 new agents in MBC. And so we have our eminent panelist with us, Dr. Gurvinder Singh. So Manish, I'm inviting your panelist for you. Is that fine?
Yeah, sure. Please go ahead.
And Dr. Kanika, Dr. Gurvinder is assistant professor medical oncology at HBCH Sangru. Dr. Kanika is associate consultant medical oncology at Max Hospital in Mohali. Dr. Ravi Jaiswal is medical oncologist at Ramakrishna Care Hospital in Raipur. And I think a couple of people I don't see here. Dr. Deepak, Dr. Nidhi, Dr. Hollis, have they joined?
No, sir.
Okay, so we have Dr.
No problem, we can start. What was the first name you took, sir?
Dr. Gurvinder is there.
Gurvinder, Dr. Kanika, and Dr. Ravi.
And we can make use of Dr. Shefali's time with us. Shefali, you are
still?
Yeah,
sure.
Yeah, I'm still there. Yes.
Shefali is also there, right?
So let me start with Dr. Shefali then. I don't have any slide set to share, so it will be very, we have had this discussion many times. So HER2 positive, how to sequence therapy. So I would like to hack everybody's mind on a few certain cases which I have been treating for quite some time. So let's say that there is a scenario of a young lady who is 33-year-old, and has a metastatic CA breast, which comes out to be ER/PR positive, HER2 positive, that is triple positive breast cancer. And assuming that she has liver metastasis, a few lung metastasis, some bone metastasis. So how would you approach in this case, Dr. Shefali?
Yeah, so triple positive.
33-year-old female with metastatic, no visceral crisis, but yeah, widely metastatic, but triple positive, HER2 positive breast cancer.
Yeah, so I have a couple of treatment options for that lady, and that would depend upon actually many factors.
What is your preference? I know there are multiple treatment options, but what's your preference?
My preference would be dual HER2 blockade plus taxanes in this setting to begin with.
So say for example, you treated, does the other panelist also agree with that? Or is there any treatment option that comes to your mind other than that? The patient says, you please give me the best. She doesn't mind chemotherapy. She doesn't mind anything. She says, I want to live, give me the best. And she has all the money.
What is the performance status, sir?
Very good. I would say PS1, incidentally detected breast tumor, but when you do a PET CT scan, lo and behold, you find that there is metastasis.
And you said she's in visceral crisis.
No visceral crisis.
No visceral.
I said specifically no visceral crisis.
Okay. So I think I agree with madam.
Option. I know that there are many treatment options, but what is your preferred treatment option?
I agree with madam. Docetaxel, trastuzumab, pertuzumab.
Okay. And so can we have everybody, Dr. Gurvinder, you agree? We can be short. If you agree, then you just say that you agree.
Yes, sir, I agree.
And Dr. Kanika, you agree?
Yes, sir. Yes, sir.
Okay, so we treat this patient with dual HER2 blockade, pertuzumab, trastuzumab, and docetaxel. Great response, and after 3 cycles, almost a complete response on radiological complete response, and a small residual disease left in the breast. What do you do next? 6 cycles completed, great response. I'm not really asking about surgery. I'm not asking about surgery, okay? Shefali,
which panelist are you asking?
Shefali.
Okay.
It has to start with you.
Okay, all right. So I'll put my patient, I'll stop chemotherapy in this case and put on dual HER2 blockade plus hormone because she's triple positive.
Which hormone?
So
she's 33.
Absolutely. So the best is I would put her on ovarian suppression and add on AI to this arm.
Excellent. Does the other panelists agree with that? LHRH agonist plus AI? Dr. Gurvinder?
Sir, why not tamoxifen, sir?
Yeah.
So why not tamoxifen, Dr. Ravi?
No, I think the best data we have is for to make a postmenopausal and achieve maximum endocrine blockade with aromatase inhibitor.
So Dr. Gurvinder, that's the answer. The maximum data is in favor of AI, especially in HER2 positive breast cancers. Tamoxifen doesn't really work well. If you have a triple positive breast cancer, it's best to use, I'm not talking of the adjuvant setting, but in the metastatic setting, there's definitely data that AI works better. Dr. Kanika, do you agree there with that?
Yes, sir.
So we did the same. We had put this patient on. We did a bilateral oophorectomy. We started with LHRH agonist. Finally, we did a bilateral oophorectomy, and then we continued with AI. Now this patient has oligoprogression in the breast. Now we go back to Dr. Shefali. Dr. Shefali, there is an oligoprogression in the breast. What do you do?
So what is the PFS actually
in the
on
breast.
the? So for how long did she maintain in remission?
She's getting now pertuzumab free of cost. She's getting pertuzumab now free of cost.
So my question to ask you was, so
practically around 15 months.
For how long she was in good disease control on these agents? That would define my next step.
15 months. 15 months.
Okay, all right. And breast is the only area of progression? So if the breast is only area of progression, I would warrant a local modality treatment for that area and continue my ongoing line of treatment.
What would be your preferred local modality in a metastatic setting?
So both radiation as well as surgery, I'll discuss pros and cons. If it is possible, surgical option is also good. Otherwise, radiation.
If you do a surgery, then you do a simple mastectomy or you do lymph node dissection as well.
So that depends
and
upon
give her lymphedema for the rest of her life.
Depends upon how, if there is a if there is an extensive nodal burden also, of course, I would not go for a surgery in that case, because axillary dissection.
Only breast oligoprogression.
Only
but
breast,
she had initial lymph nodes to start with.
Right. So simple mastectomy would be my take. It is an oligoprogression dealt with the
oligomodality. So between radiation and surgery.
So I would discuss with the patient. That would, again, the patient decision would matter. So my choice would be both on cards, of course, surgery, and then if not, then radiation is the good choice. Because surgery would give me the advantage to see what was the reason for oligoprogression. I could test it for NGS. I could test it for.
You can achieve it by doing a.
Sorry.
Can we go ahead with a biopsy first and then go ahead with the surgery or other to see whether?
So biopsy done, Dr. Kanika, biopsy done, it proves that it is still ERPR positive, HER2 positive breast cancer. What do you do next?
Then surgery.
Surgery or radiation?
Surgery.
Surgery. Okay. So two people say surgery. Ravi, Dr. Ravi.
I think for the breast, I think surgery would be better.
Surgery would be better. Okay, Dr. Gurvinder.
I think it's a simple mastectomy.
Simple mastectomy. And do you follow this up with a radiation therapy or only surgery? That's it.
Only surgery.
Surgery.
Only surgery. So what we did only radiation. We did not do surgery. I thought that surgery is too much. It's an invasive thing when you can get better by doing a non-invasive modality than by an invasive modality. So we did radiation. The patient performed well. Now she has 2 brain metastases. So, and systemically, there's no progression of disease, but only 2 brain metastases. Now back to Shefali. Shefali. Okay, we'll hack Dr. Kanika's mind. Dr. Kanika, what do you do next?
Sir, patient is symptomatic and there is only 2 brain.
The patient had thrown up a seizure, and that's the reason we got to know brain metastasis. And when we did, she didn't have any neurological deficit, so only brain metastasis, which we picked up on a seizure. After that, there was no seizure.
So I would like to go ahead with SRS for the brain lesions, since there are only 2 lesions for the brain.
Yeah.
And then I would like to change the systemic.
Change the systemic therapy.
Yes, sir.
To what? She's on trastuzumab, pertuzumab, and letrozole.
So I would like to change it to TTM1.
Why?
Because the patient has progression with brain met, so I would like to change.
But systemically clear. There's no metastasis, no progression of disease. Radiologically, she is almost in complete remission.
Yeah, but there is some resistance. That's why the patient have brain mets in the first place. So,
if brain is just a sanctuary site only, these brain metastases were always there, which were never picked up, and they just progressed and caused symptom.
But Dr. Manish, 3 years down the line, if still brain mets are not progressing in the sanctuary site, I don't think that it was already there 3 years down the line and they have progressed it now.
So these are all skeptical things. There's no clear indication. There's no clear definition of. So what do you like to change, Shefali?
So if the option is available, trastuzumab deruxtecan, obviously.
Trastuzumab deruxtecan, of course, we know that it has got CNS response of around 60%, if I'm not wrong, from the second line data, the Destiny 03 or 101, whichever it was.
So 70% intracranial response rate.
Yeah, almost 66% intracranial responses. Yes, you're right. But that option doesn't exist in India. So what do you do?
So again, I mean, if we are pretty sure that there are only 2 meds, there is no leptomeningeal enhancement. I mean, still the option exists that SRS for both of them and continue the existing treatment. I would still like to observe the biology.
Dr. Gurvinder, what do you do, sir?
Sir, if
patient is getting free pertuzumab now. And now Phesgo is coming free. No, she doesn't even have to pay for the trastuzumab.
So we have done the SRS, sir. Brain has been addressed.
Yeah,
So
SRS done. She's asymptomatic now, doing happy. Everything is hunky dory.
In this case, I would re-challenge again with docetaxel and continue pertuzumab and trastuzumab.
Why do you want to give the toxicity of docetaxel? She's systemically clear. There's no disease. How would you gauge your response with docetaxel? Docetaxel doesn't go to the brain.
Now, docetaxel doesn't go to brain. Yes, sir, that's absolutely right. But adding chemo, maybe there will be a PFS benefit again then.
Okay, so how do you gauge PFS? By no brain metastasis in the coming years?
No, not in the brain, sir, but systemically.
And you will continue Phesgo or pertuzumab, trastuzumab.
Yes, sir.
And Dr. Ravi, what's your thought?
I think I'll go to TDM1. The generic is available. I think we'll go to that generic TDM1 because.
So what is the response rate of TDM1 in the brain? Shifali, you just told us about the Destiny trial, which was a head-on comparison of TDM1 with trastuzumab deruxtecan. Hardly any, maybe 20%. That is what it was. 22%, if I'm not wrong.
Yeah, 22%.
22%. Well, yeah, perhaps you're right. There's nothing wrong in TDM1, in shifting to TDM1. There's nothing wrong.
That is slightly better than your trastuzumab, pertuzumab. It will at least maybe.
I'll tell you what happened in the Amelia study. In the Amelia, which was a lapatinib, capecitabine versus TDM1 study, those patients who had a CNS metastasis, it was not a direct comparison, but the progression-free survival in the CNS metastasis patient was 25 months put against around 9 months or so in lapatinib, capecitabine. I don't know how much we can follow up on that, but certainly TDM1 has got some CNS penetration and CNS activity. So there's nothing wrong in shifting to TDM1. But we continued with trastuzumab, pertuzumab, letrozole, and we kept chasing these brain metastases. So far, the patient is doing well. We radiated her in March, maybe in February 2022. She's doing well. In the subsequent MRI scan, there was no progression of disease in the brain. As a matter of fact, whatever lesions were there, they decreased in size. So TDM1 is definitely one of the options that I would shift on once she progresses further. But taking into account this particular case, I think since pertuzumab and Phesgo is coming totally free of cost, he's thinking of keeping the cost less and still continuing treatment with the free Phesgo. So one more case scenario, and then perhaps we will close it. So what if this progress? Maybe we can just extend this case. So what if this patient has a ERPR positive tumor and has been exposed to TDM1 and progresses again systemically this time, and this time she has, say, another liver metastasis, and you biopsy that liver mets, and it comes out to be triple positive breast cancer still. So your thoughts, Dr. Ravi, about using CDK4/6 inhibitors in such cases?
I think I'll pass this to Dr. Shefali.
All right. So if
you seem to be the expert over here. Okay.
Again, if the options are available, so I mean, if she has progressed systemically, so my choice would be margetuximab or neratinib plus capecitabine in this setting, which was scoring above the cape lab actually in this setting. We have this trial now. But so
lab cap versus neratinib cap is definitely neratinib cap was better. I think that was the Nala trial.
Absolutely, yeah.
That was the Nala trial.
And margetuximab was actually trophy. So that was both of the options in this setting. But
so where do you place CDK4/6 inhibitors in a triple positive CA breast? I know we don't have approvals, but we do have a Monarch trial, Monarch HER2 trial, which showed that there is benefit. And that was in very heavily pretreated population.
Absolutely. So I'll place it there only, very heavily pretreated, beyond third, fourth line. That would be my choice.
So actually, Manish's Monarch HER is actually an exciting data in triple positive. I think we need to incorporate CDK4/6 inhibitors somewhere in such scenarios.
So I'll change the scenario, Sachin, since you talked about it. Now this patient had a liver metastasis progressing, and you did a biopsy. It comes out to be FISH 1.9, slightly HER2 negative, and it is ERPR still positive. And I'm telling you, this scenario happens. This scenario happens. It has become HER2 2+, and the fish is just borderline positive.
No,
Shifali, what do you do?
Doctor, yeah, so that is what I was, but if down the line, so many multiple lines treated, if you lose HER2 expression, does that mean that she's now becoming HER2 negative? No, I don't think so. So, of course, this
The
heavily
biology
pretreated
is changing. Then what's the fun of doing a biopsy again, which people do?
So the point of doing biopsy again is maybe we can see how strong is expression of ERPR till now, not to decide about whether she has lost HER2 or she has, I mean, retained the HER2 expression to my mind. So of course, CDK4/6 inhibitor and the hormone therapy or AI for that matter is on the cards.
So even in the Monarch, they continued they have continued the trastuzumab. They didn't stop the trastuzumab. So I'm not proposing to stop trastuzumab, but how gung-ho you are about HER2 targeting in a patient who is losing on the HER2. We know that these patients do tend to progress, and perhaps a heterogeneous population keep progressing, which becomes HER2 negative.
Yeah.
So,
I
only
agree
question
with you
is
on
that
that.
whether you would like to invest a lot of faith on a HER2 targeted therapy in a patient like this, or whether you would like to go the other way.
In heavily pretreated patients, of course, trastuzumab is a wonderful drug. I do not rely upon any of the novel agents, but for trastuzumab in this heavily pretreated setting. I have a couple of patients, and I'm sure all of us have it, where still post multiple lines down the treatment, still hormone and trastuzumab, I mean, do very good for patients for quite a couple of months. They do really well. So I agree with you. Continue. Yeah, trastuzumab.
Last part of the discussion. If this patient could not afford pertuzumab, Dr. Kanika, how would you treat this patient?
Now, after these multiple lines of treatment?
No. Upfront, if this patient came to you, pertuzumab is not doable, then how do you treat?
So then also just removing the pertuzumab out of the picture, I would like to treat with the docetaxel and trastuzumab, and then put on maintenance trastuzumab and hormonal therapy along with ovarian suppression.
Would you like to add lapatinib somewhere down the line?
Sir, if the progression...
Now we have data from alternative trial, not during progression, but otherwise also. Say, for example, you treated with trastuzumab, docetaxel, great response. Now the patient is on trastuzumab plus letrozole plus lapatinib. Would lapatinib serve the purpose?
So if the patient
based on the alternative trial, which was a JCO publication, and if you look at the NCCN guidelines, that is what they dictate. Trastuzumab, lapatinib plus AI in a triple positive breast cancer.
So if the patient is not progressing like multiple visceral metastasis or in crisis, and if there is only a few nodal mets or bone mets, and the patient is asymptomatic, then yeah, instead of re-challenging with chemotherapy, I would like to go for trastuzumab, lapatinib. And
once your chemotherapy ends at 4 months and you have achieved a great response, how do you improve the progression-free survival on trastuzumab and letrozole alone versus trastuzumab, letrozole plus lapatinib? That's the question I was trying to ask.
Not upfront, sir. On progression, I would like to add, but initially I would like to give only trastuzumab.
I'll just highlight that there is a study called as alternative trial in triple positive breast cancer. It was a phase 3 trial. It added lapatinib and showed that the PFS reaches almost 11.2 months, whereas with trastuzumab, letrozole alone, the PFS is just about 4 months. So if the patient is only on trastuzumab and letrozole, you're likely to achieve a PFS of around 4.5 months alone. But if you add lapatinib, you reach a PFS of around 11.2 months, which even the NCCN guidelines also say that a triple positive breast cancer can avoid chemotherapy altogether and go on to trastuzumab, lapatinib, and letrozole. Dr. Gurvinder, your thoughts?
No, sir, I'm not aware of the study, sir.
Okay, fair enough. Ravi?
I'm aware, but I have a couple of patients. I'm continuing them on trastuzumab. I'm not very keen on adding lapatinib, to be very honest.
Okay.
Because
I'll just share my experience of 5 patients who they were elderly, they were 60 plus, had a triple positive metastatic CA breast. I didn't give them any chemotherapy. I gave them lapatinib, trastuzumab, and letrozole. One of them is at 5 years doing very well with lapatinib, trastuzumab, and AI. One is at 3 years doing very well, 3 or 4 years doing very well. And another one is about a year doing very well, almost disease-free on the PET CT scan. And most of them are doing very well with this combination. And most of them are are definitely above 60, wherein I didn't want them to take chemotherapy unnecessarily. But the combination really works very well.
So what dose you are
Shefali,
giving elderly patients lapatinib?
Yeah.
What dose of lapatinib you are giving for the elderly?
lapatinib, I generally give 1000 milligram with trastuzumab. That's the indication. You don't use 1250, but many of these are on 750 to 2000, but definitely not less than 750. So if you go by the package insert of lapatinib, below 750 is ineffective. That's the lowest effective dose of lapatinib.
That's excellent, Manish. I think that's the highlight of the panel discussion.
Yeah, I also have a couple of patients on this combination.
Yes, even I have used this.
Either I started upfront or I use it at progression. I do not consolidate my response by adding on lapatinib to AI and trastuzumab.
So that's fair. I agree.
Progression, so not continued like that, as Shefali said. But I think Manish has a point, and this data backup is always also there, which shows a good PFS benefit. So that is a valid option actually, at least in our setting.
Yeah. Especially when lapatinib is now dirt cheap. I said that lapatinib is very cheap.
Yes. It does make absolute sense in our scenario. That's what I'm saying. I think, thank you, Manish. Can we conclude now? I think that's the...
Yeah, please, we can conclude. Thank you all the panelists. Thank you, Shefali, for staying back. And thank you, Dr. Kanika. Thank you, Dr. Gurvinder. Thank you, Ravi. And back to Dr.
Thank you,
Sachin.
Dr. Manish, for, as usual, the bang-on discussion.
Thank you, ma'am, from our side for taking the question first.
Thank you. I think that was very quite interesting, actually.
If you can answer my question on the chat box, the panelists. Thank you.
Yeah. Okay, I think Shefali, maybe you can do that. Meanwhile, I invite Dr. Chandragowda because we're getting late.
I was reading that question just once.
Please do that. Okay, so the next, so Dr. Chandragowda is free now, and we are about, let's say, 8 minutes behind the schedule. And I would request Dr. Chandragowda to now stick to his time so that we are not late for the next session and keep other people waiting. So Dr. Chandragowda is Associate Director, Medical Oncology at DLK Super Specialty Hospital in Delhi. And so it's a Roche-sponsored academic session where he would be discussing on optimizing therapy in HER2-positive breast cancer, new paradigm shift in cancer care. So Dr. Chandra, please.
Thank you, Dr. Sachin. Thank you. I'll just, without wasting time, without much, I'll move on to my topic. Let's transform the journey from our HER2-positive breast cancer patients. I think slides are visible, right?
No, sir. You didn't share your screen, sir. First, please share your screen.
No.
No, sir. Please click on share screen button, a green color button at the bottom side, sir. Then click on screen, then click on share, sir. Yeah, now you done, sir. Go to slideshow mode.
Yeah, let's do that. Yeah, these are my disclaimers.
Perfectly done.
So we know that the Perjeta Herceptin has transformed the treatment landscape in the management HER2-positive breast cancer, be it a neoadjuvant, adjuvant, and a metastatic setting. I don't want to go into the details of this. And we know the landscape of management of a newly diagnosed HER2-positive breast cancer. So the indication for neoadjuvant, I think a lot of them, we are all medical oncologists would definitely treat it as a systemic disease and start neoadjuvant PCHP, and then move on to a further risk stratification depending on surgical this thing. So that's what has been taught. And now, what used to be an issue in this till now was the longer infusion time. And moment we started hearing about that, can this be given subcutaneous? So the treatment time was drastically reduced. That was a good advantage of using these two combination. The long infusion and observation time, the congestion at clinics and hospital, and then the challenging of improving resource utilization. That was also a point. And then a placement and maintenance of the port or a PICC lines. So the secondary infections, the thrombosis, they were the problem. And the challenge of the venous accesses, especially using only one limb in breast cancer patients. So all these challenges were met with one injection called as the Fesco, where we can probably just give a subcutaneous injection with high, and then patients can be cured of these issues. So this contained 2 monoclonal antibodies in one syringe, and it comes as a bolus 15 ml loading dose followed by 10 ml maintenance. And it is combined with recombinant human hyaluronidase, which allows us this dose of subcutaneous administration. It comes as a fixed dose formulation given over 5 to 8 minutes in the thigh. So the mechanism of action is completely similar to what the IV dose is. So the blockage of HER2 and HER2/3 dimerization and HER2 blockade. So that's what is same. And what is important is the recombinant hyaluronidase. So as you know that in the subcutaneous plane we have these the collagen fibers. So I'll just see, this is a cartoon network showing that these collagen fibers would not allow us to deliver the more doses of the subcutaneous any injection. So what hyaluronidase does is just these particular wires and then allows the 15 or 10 ml dose to be given adequately, creating a subcutaneous tunnel. So that is an advantage. And I've already started 2 of my patients, and they're happy. And then it is not creating any lump as was seen like this. So without recombinant hyaluronidase, this is how the lump that you can see post subcutaneous. But here, hyaluronidase, you can see there isn't any lump. So does pH FDC have the same pharmacokinetics, efficacy, and safety as per IV? So look into that. We have there is a clinical development program of FESGO. So the first was BO30185 is a dose finding study, and then after that the dose was fixed to 1,200/600 as a loading dose and 600/600 as a maintenance. And then PK/PD studies were performed using Feredica study as a phase 3 randomized plain EBC, and then PH norms. This was the ongoing. Both are ongoing, but the interim and primary analysis was present in the SABCS in 2019, and this one in SO 2020. And this is more of a tolerance and the patient compliance. This was the efficacious study that was done. So if you can see the dose finding study, this was a FESCO dose finding study of various cohorts. Ultimately, I don't want to go to the details of this, and they fixed the dose into 1,200 and 600 as loading, and then 600/600 as the maintenance without any safety concerns compared to the IV medications. Then this Feredica phase 3 randomized data of patients with operable breast cancer or locally advanced breast cancer, and they were randomized into investigator's choice versus the chemotherapy, that is AC followed by T, and that with the IV pH in the red, and this is this one subcutaneous formulation in the green. So they've then done surgery, and then ultimately IV versus the subcutaneous was continued. And the primary endpoint was non-inferiority from cycle 7 onwards, and the key secondary endpoints were non-inferiority cycle 7 and the serum concentration of H and P and TPCR and safety data. So if you can see the pharmacokinetic data of these, you can say that there are 3 parameters: the C trough, the AUC, and Cmax. These are 3 parameters on the pharmacokinetic basis. The down this graph, which is a subcutaneous, and this top one was IV. You can see the IV just takes off immediately as the IV concentration by already immediate, and then the subcutaneous takes slight time to reach the Cmax. But once it reaches the Cmax, it just crosses over the IV, and then it maintains throughout before the next dosage. So the C trough and the AUC and Cmax are concordant with what the IV doses are. And if you can see the primary endpoint of C trough plasma serum, P serum plus, and the H serum C trough, this the red bar of IV, and then the green was of subcutaneous. You can see it edges over slightly better than the IV. So also the H1, and the lower limit of 90% confidence interval for P serum and trough and GMR, and the H serum trough exceeded a non-inferiority margin of 0.8. So that was concluding that it was non-inferior. If you talk of the TPCR in intensity to treat population, and you can see almost everything, it's the same 59% plus percentage of whether it is IV or subcutaneous. You can segregate this data into a body weight. Overweight and an underweight are the one which are probably indicating that there's inferiority of a subcutaneous dosage. But you can look into the numbers, number 3 and number 7. So really cannot take this into credence as the significance cannot be attached, but nevertheless, this point needs to be remembered. And a patient who is underweight, this pathological CR rate in subcutaneous formulation is lesser, whereas in patients who are obese also the pathological CR rate is compared to lesser when you give a subcutaneous FESCO. When it comes to a safety profile of any adverse events or a grade 3 adverse events, any serious events or death, they are matching with what IV dosages is. There is no difference whatsoever. And if you talk of the most common side effects, adverse events, so AIs, that is alopecia, nausea, or diarrhea, that is more related to the chemotherapy. Diarrhea can be Perjeta related plus the chemo related. So they're all matching without any significance attached to the subcutaneous or anything, and overtly increasing incidence with the subcutaneous dosages. See them same in the bar diagram, be it diarrhea, neutropenia, cardiac dysfunction. Even cardiac dysfunction is almost similar to what the IV has seen. And the IRR and ARR, the reactions within 24 hours, the anaphylaxis, mucositis, or ILD, all were similarly and with service IV and subcutaneous formulation. So there isn't any meaningful difference between the treatment arms as far as the cardiac events or the secondary cardiac events are concerned. So when we talk of a cardiac event, when you're doing dual anti-HER2 blockade, there isn't any difference between primary, secondary, or LVEF declines down the line. So this is what the conclusion of this particular study was, that the pH, that is FESCO FDC subcutaneous formulation, non-inferior to IV formulation cycle 7 in terms of C trough concentrations. So also the TPCR rates also was bang on similar. The safety profile was also comparable. So do these patients prefer these FESCO combinations over the IV? That was a study from PH Ran's study, where all the HER2 positive patients, the EBC was completed the neoadjuvant pH and chemo, and the surgery was they were randomized between the IV versus subcutaneous, and then crisscrossed over the subcutaneous versus IV and tried to analyze which one they preferred. So that was an intent of this particular study. So when the analysis was done, you can just see that the all things considered, which method of administration did you prefer? So the preferred was the subcutaneous. So it was almost far more faring better compared to IV population when the preference is concerned. So preference for the FESCO was very and fairly strong to a majority of patients. The main reason for subcutaneous preference was less time in clinic, more comfortable, and 87 chose to FESCO to continue the treatment. This is also when you talk of the healthcare providers, they are also very happy in terms of time consumed. They can spend more, around 8 to 10 months discussing while the subcutaneous injection was being given. And this is in the majority, the preparation room, it takes less time, and the treatment room also it takes less time. So it's only around 10 minutes, though we observe for 30 minutes, but it's around 10 minutes of time which it takes into credence, and that the patients can go home. So the adverse events in the PS trans also are bang on similar between the IV and subcutaneous formulation. So this is conclusion saying the main reason for FESCO preference is less time clinic, more comfortable during administration, patient satisfaction. They're very satisfied, almost 90% satisfied in the subcutaneous formulation, and more patients indicated that there's no impact on the amount of time they spend talk to a doctor and the clinician. That the HCP prescription was also much, and there was no safety concerns as a subcutaneous formulation concerned. What are the practical considerations that we give? So when we started giving some patients in the clinic, it is important that patients should be comfortably sitting with the thigh exposed, and you should use the thigh alternatively, one thigh at one time. And if you use the left thigh initially at the outside and the right side for the next time, and there should be difference. They should mark it out, or you should know that where you are given it, as there should be around 2.5 centimeter difference from one injection to another injection when you give it the next injection. So that should make 30-degree angle with the syringe and the pinching up with the two fingers, make a 30-degree angle, and then just in one syringe, you should not divide the dose. The same syringe has to be infused over 8 to 10 minutes, and the patient has to lie down in there for 30 minutes time just to observe in the first instant, and then next time out, only 15 minutes should be enough. So that's how this injection is being given. And this is the best practice that depending on the hospital outpatient, the doses can be administered on a dedicated date, and then patients can be gone. And what my patients have felt, the two patients have started, they're comfortable using the subcutaneous days, and they're very happy that, and somebody who have switched over, they're very happy that yes, they have to spend less time in a daycare and that can be finished. And sometimes what else you can do is the port can be foregone. Because in all the patients used to just say that yes, you have to go for the port keyboard or pick line. Now in this scenario, you can say that the port is not required. You can just TC, you can give an IV, and then first we can give subcutaneous. So that's the advantage of this, and this becomes more patient friendly and as well as healthcare friendly drug. And I think this is what the HCPs have and the patients preferred. This is just a final the conclusion saying that yes, this is the way to go, and a patient is affordable, and this also costs lesser compared to IV preparation, and it consumes less time, patient and healthcare provider friendly. So that I conclude my talk, and thank you very much, Dr. Sachin, for the and thank you, Raj, for the opportunity. Thank you.
Yeah, thank you, Dr. Chandragowda. And so this combination, of course, is going to help us and help patients in, and so ease of administration, less time, and a lot more benefits also there. And cost also improves. And so we move on to the next session now. So shifting gears, going for ovarian cancer. So the breast cancer session is over. And we have Dr. Piyush Bajpai with us now, who is HOD and consultant medical oncologist at Manipal Hospital in Delhi. And so Dr. Piyush is going to talk on how do I integrate PARP inhibitors in advanced ovarian cancer treatment, upfront and relapse setting. So this is going to be followed by a panel discussion on advanced ovarian cancer treatment. And so Dr. Piyush, go ahead, please.
Yeah. Thank you, Dr. Sachin. So I hope my slide is visible over there. So thanks once again, and the topic given to me is integration of PARP inhibitors in advanced ovarian cancer management, frontline and relapse settings. So now in the frontline settings, coming to it straight away, what is the biomarker in the first line? There has been a bit of practice change, what at least in my practice, and I'm sure my colleagues also would have experienced that we were all looking at BRCA mutations, and then eventually HRR mutations till last year, and then after that HRD all of a sudden has come into practice, and we have now switched gears towards HRD in frontline practice. So what is the biomarker? What treatment options do we have right now in 2022? Though all drugs are not available to us, but of course we have a couple of drugs, and the PARP inhibitors for all comers. That's the question that is important. So just to touch base on the molecular biology of it, and we know that these set of genes in the red box over there are responsible for homologous recombinant repair, which is the double-stranded break, and these genes are responsible to repair that. And if in case there is a deficiency of these and you give a synthetic lethality, a PARP inhibitor over there, so you have a single-stranded break ongoing, which converts to a double-stranded, and these HRR pathway is not there to actually mend the breakage which happens, and eventually what leads to is then the apoptosis of the cell. So, well, talking about biomarker and BRCA1, 2, and 2, somatic and hereditary, this has been always a question. Well, now it is adopted that by various guidelines, all the societies, all the leading societies, that all women with ovarian cancer should be actually considered for genetic testing, and that's very important in high-grade serous ovarian cancer. So this, as well as, of course, endometrioid, where genetic testing should be considered. Why is it so important all of a sudden, and has grain, come into the picture all of a sudden? Is one of these trials is this, and you can see that in this particular solo 1 trial, the after 24 months, the curve starts to flatten out. there aren't many failures happening, and especially in patients who have achieved CR. That is there is no disease post completion of chemotherapy. These particular set of patients are actually doing pretty well, and this is not a fair comparison though, but this is what the graph is looking like in the upfront maintenance setting, where BRCA mutated solo 1 data is going beyond this, all reaching all barriers. So more than 56 months. The other drugs also are showing quite similar, outcomes in this particular population. So it is important that we do BRCA 1 and 2 genetic mutation to gain this advantage. However, beyond BRCA 1 and 2, there has been now biomarker in terms of HRD, and this is probably what the gene, just the not about gene only, but probably post translational changes or epigenetic changes, that is methylation of the promoter BRCA. So there comes the importance of HRD, and this evidence we have from Ariel 2 coming right from 2014 publication, where this Ariel 2, where rucaparib actually showed its benefit even in a BRCA wild type and LOH high, the benefit was present. And if this benefit was present, then there was definitely something more than BRCA. So the HRD, the thought process of getting a HRD score was being established over there. Again, this forest plot of the same trial, and you can see over there that BRCA 1 and 2 patients are doing well. To note over here is RAD 51C and D, which these patients are also doing well. And apart from that, of course, the loss of heterozygosity was important. If it is high, then these patients were doing well, even if they were BRCA negative. And again, Paula 1 actually showed, brought HRD again in the center stage, where HRD positivity, even if it's non-BRCA mutated, there the PFS advantage is being there, though the delta is slightly smaller, but the PFS advantage is there as compared to where HRD is negative. And now this brings importance of actually, it being a strong biomarker. So you can see that the curves are absolutely sticking to each other in the third graph over there. So HRD becomes an important biomarker. Now, in between, we had all started doing HRR as, mutation testing a set of genes. And HRD and HRR are not synonymous. And this data has come from, again, from the Paula 1. And here we have understood that probably this is not the way we should be looking at for this particular PARP inhibitor. So HRR is not causing a genomic scar. So the new crown for biomarker goes to HRD, and therefore HRR is out in the frontline setting. But now here comes the PRIMA data. Now PRIMA is the data for niraparib in the upfront setting, and it is again breaching all the thought processes that, HRD, and even if in case it's HR proficient, you have the progression-free survival advantage over there. So there lies the importance whether is there something more than HRD, which we really do not know. So PRIMA is probably pointing out towards that, and so this particular thing actually, this particular drug actually pushed away HRD, it seems. But for now, HRD is in practice, and that's what we are using for the current, olaparib, and HRD is definitely in for now. Of course, PRIMA data does tell us that, probably way to go forward would be looking at the NGS as well as HRD. So that becomes important. Well, this is how the integrated maintenance treatment paradigm for first-line ovarian cancer is looking like. If you are actually incorporating bevacizumab early on, then you need to actually consider which way you would be going. Of course, the thought process of doing a somatic and Bracha testing should start after, once the patient is diagnosed. So this process should start, and so you can decide what treatment strategy would you be fitting your patient towards. So this decision should start because whether you want to go for a switch PARP maintenance or whether you want to go for a bevacizumab and a combination. So this basically, if you have information on HRD as well as genetic germline testing, then it becomes easier to choose your patient for maintenance. Switching gears towards relapse settings. What is the biomarker we look at? What is PARP inhibitor current data, quality of life in relapse, and can we overcome resistance of PARP inhibitor once they are failing, then what to do? So HRD assay has a limited utility after platinum exposure. And this data comes again from Ariel 1, Ariel 2. And here again, what was seen that, loss of heterozygosity, low BRCA wild type, it really did not matter. Rucaparib was working over there. Solo 2 and got OV21 study design was actually showing that if you are choosing patients with the germline BRCA1 and 2 mutation, and what was important that there should be platinum sensitivity as well as a response to the previous platinum treatment, CR or PR on most recent therapy. So that becomes important. You need this while you are putting your patient on olaparib. So you need some response to the chemotherapy before you are putting your patient on olaparib. And the forest plot in this particular trial also showed that the minimal disease burden over there was also important. Again, niraparib is actually taking similar set of patients where the previous platinum-based chemotherapy is showing some response, partial response or complete response. So again, this trial turned out to be positive for germline BRCA mutant, and for the non-germline BRCA mutant was also taken. So the germline BRCA mutant, the PFS was 21 months versus 5.5 months. For non-germline, it was again, niraparib is a different drug probably, 9.3 months versus 3.9 months. So here, all-comer data is present. For Ariel 3, again, they have taken sensitivity to penultimate platinum-based chemotherapy before putting on maintenance. So again, sensitivities to the platinum-based chemotherapy is important. So rucaparib is positioned over here in maintenance in post relapse setting, and it's being continued in and the primary endpoint was PFS. Secondary endpoint was PFS as per investigate central review, and PROs and overall survival, safety and pharmacokinetic analysis. So if you look at the phase 3 PARP inhibitor data in the maintenance setting, what are we finding over here is that the PFS, if we look in the various subtypes, if we look at the BRCA mutant, we find that the PFS is quite similar, 21, 19, 16.6. HRD positive, quite similar PFS with the niraparib 12.9 and 13.6. Again, for the wild type, 6.9 and 6.7. So though not again a fair comparison, but the hazard ratios seem to be quite similar in all the PARP inhibitors, especially once they are being used in the relapse setting as a maintenance therapy. So probably the drug over here, then you have to probably choose which drug to choose in this particular setting. You would choose it according to the side effect profile because the PFS are quite similar over here. But again, there is a differentiator. Solo 2 data, you are getting an overall survival over here, and you get an overall survival of nearly 51.7 months versus 35.4 months. And this is despite that the patients in the placebo arm eventually got PARP inhibitors. So this is important. But in Nova ENGOT study, you see that the curves are actually, so overall survival benefit is not really happening over there. So this is important, and probably one would consider choosing more of olaparib in such a scenario if maintenance is being considered in a relapse setting. So should we choose PARP inhibitor in the first line? Yes, if we look at the previous graph, as I said, you know, the Solar 1 data as well as the Paula data. So there the PFS is pretty impressive if we compare the PFS with the Solo 2. So again, the overall survival, duration of Solo 2. So definitely, this is a drug. If in case it's being used earlier, you're using this good drug earlier, you can get the best of benefits. But there is also a flip side to it, that we need to understand that once the patient would progress on such a drug, they would not respond well to platinum therapy, and they would progress pretty fast. So there are certain particular monitorings that need to be done, and niraparib is actually notorious for hematological toxicities. So the drug is also adjusted as per weight, as per platelet. So the drug adjustment is required. For olaparib, basically not much of a toxicities are there. We all have used, not many toxicities. Likewise for rucaparib, some transaminitis is there that we need to be careful for, but otherwise not many toxicities. Not the very usual toxicities. So, but then what is important is that we need to understand that if these patients start having anemia or thrombocytopenia, we need to actually be very wary of and look for MDS clone coming up. So that is very important. And one important point over here is that after your chemotherapy is done, and the counts should all recover before you start maintenance strategy with PARP inhibitor. So this is what it is, that if you are using your best drug upfront, you would have probably the best PFS upfront, but then shorter PFS later because your platinums are not working great. So there lies the challenge, what to do. And then here are some answers coming from this particular trial, Oreo and got OV38, where patients who have been already exposed to PARP inhibitors, their olaparib is again, after chemotherapy being again used in maintenance setting. And here, what was seen that both in the BRCA mutant and the non-BRCA mutant cohort, there was a PFS advantage seen. So there is some ray of hope in patients who have progressed on maintenance strategies, have got PARP inhibitors earlier, can be rechallenged with PARP inhibitors, and some responses we could get. So looking at PARP inhibitor resistance mechanisms, basically what we see is there is restoration of homologous recombinant activity by various pathways, the EGFR, MET, and VEGF pathway. And there have been trials combining PARP inhibitors with VEGF, oral VEGF, as well as IV bevacizumab. And then there is mitigation of replication stress. That is, the fork stability gets the fork gets stable, and the resistance by multiple mechanisms, including the ATP pumps. So these three are the major mechanisms. And so this particular trial, ANANOVA, basically is looking at bevacizumab versus bevacizumab plus niraparib versus niraparib. This is a phase 2 study, and what they have got as PFS as a primary endpoint, that there is a benefit of using niraparib with bevacizumab as compared to niraparib alone. So probably anti-VEGF is overcoming some resistance of PARP inhibition over there. And another important pathway is the V1 pathway. What we are seeing is, which is controlling the CDK 1 and 2 phosphorylation. And this particular pathway, if V1 is actually blocked, And this is a drug, adavosertib, which has been used with olaparib and without olaparib in such a situation patients who have already got exposed to PARP inhibitors. So what was found that you can see the overall response rates over here. This was a phase 2 study, so overall response rates were looked at, and adavosertib is working with or without olaparib, both in BRCA wild type and as well as BRCA mutated. So the current approvals right now for the frontline maintenance basically is there for niraparib. It's there in irrespective whatever your HRD mutation status is. For olaparib, it is there for germline, somatic, BRCA, and of course HRD deficiency. So where we can use olaparib and bevacizumab. Any BRCA mutation or HRD in recurrent maintenance setting, any BRCA mutation or HRD status, platinum-sensitive disease is a strong biomarker, and these 3 drugs can be used over there. For recurrent treatment, of course, germline or somatic BRCA mutated for more than 2 lines of therapy, rucaparib is used, and likewise, the olaparib and niraparib in more than 3 prior lines of therapy in germline BRCA mutated, or niraparib BRCA mutated or HRD positive. So to conclude, PARP inhibitors have made a change in how advanced high-grade ovarian carcinoma are treated. Survivals have improved, and so also the quality of life. Upfront maintenance strategy is promising, and biomarker currently we have one of the best biomarker is HRD, but NGS probably is also going to be required in future. In relapse scenario, also the best outcomes when the disease burden is small, and so therefore platinum sensitive disease with a CR probably in relapse scenario is one of the best biomarker to add these drugs. Overcoming PARP inhibitor resistance strategies are in pipeline, and one must check all patients for germline mutation BRCA 1 and 2 for sure. Thank you.
Thank you, Dr. Piyush. You have beautifully summarized it. And of course, these are, newer drugs, and we are beginning to, use this and learn more about these agents. And of course, cost remains a constraint, and it becomes sometimes difficult to administer these agents to many patients. So thank you so much. And now we move on to the last session for the day, which is the panel discussion on management of advanced ovarian cancer. And we have Dr. Amol Dongre, who is a senior consultant medical oncologist at Alexis Multispecialty Hospital in Nagpur. And we have an eminent panel with us. Dr. Amol, should I invite the panelists for you? You are on mute.
Please. Yeah, please.
So we have Dr. Satinder Kaur. She's a clinical lead and senior consultant gynae oncology. She's a gynae oncologist at Dharamshila Narayana Super Specialty Hospital in Delhi. Welcome, ma'am. And Dr. Ketan Jan is a fellow consultant medical oncologist at Fortis Hospital in Mohali. Dr. Taha Sethjiwala is he's a consultant medical oncologist at SRJ CBCC Cancer Hospital in Indore. Dr. Wasim Abbas is a senior consultant medical oncologist at Max Super Specialty Hospital in Delhi. Dr. Pinaki Mahato is Director Medical Oncologist at SCG Cancer Center, Vadodara. And Dr. Rushabh has also joined, right?
Yes,
Dr.
sir.
Rushabh is Founder Director, Oncovine Cancer Center, and is a medical oncologist at Narayana Multispecialty Hospital in Ahmedabad. And I think Dr. Mukesh and Dr. Novak couldn't join. And Dr. Mohit is there?
Yes, sir.
Dr.
Sir, I am there. Yes, sir, I am here.
Mohit Saxena is a consultant medical oncologist at Narayana Super Specialty Hospital in Gurgaon. Dr. Sekho is there? Sekho, ma'am. Surbi, has she joined?
No, sir. There is some network with her.
All right.
And
So we
sir, Dr. Mukesh Bansal joined.
Sir, I am there, sir. Good evening.
Dr. Mukesh is also joined. Yeah, great.
Yeah.
Login शुरू हो गया ना
So Mukesh is a consultant medical oncologist at IV Hospital. So we have one gynae oncologist, and the panel is heavy with medical oncologist. Satinder, you have a good task to handle. And Amol, the stage is all yours. You can begin.
Yeah. Hi. Good evening, everyone. I know this is the last topic for today's discussion, and we have Dr. Satinder Kaur, ma'am. Hi, ma'am. Hope you remember me. Good to see you, ma'am, after so many days. Ma'am, ma'am, please unmute yourself. Ma'am, please unmute.
Yeah. Hi.
Yeah. Hi. I'm good, ma'am. Glad to see you, ma'am, after so many days. So we'll be directly going to the case-based discussion on ovarian cancer. Organizers, the technical team, can you please share my slide? I'm not able to share the screen. Can you please share? Yeah. Right. Make it PowerPoint, no? Make it PowerPoint presentation. Make it a PowerPoint presentation. Slideshow, yeah. Yeah. So next slide. So, just now we have listened to Dr. Piyush Vajpayee's excellent talk about the basically how to integrate PARP inhibitors in advanced ovarian cancer treatment upfront and relapse setting. So what I'll be doing, I'll be discussing two cases in view of we have less time. So my first case is basically she's a 51-year-old female with abdominal distension. Her CA-125 was 1050 international unit per ml. She was ECOG performance status 1. And in a significant past history, her mother was diagnosed with breast cancer at the age of 52. Next slide. Next. Yeah. So on diagnostic workup, she was diagnosed to have high-grade serous ovarian carcinoma, FIGO stage 4B. Next slide. So, in view of FIGO grade stage 4B with high-grade serous ovarian carcinoma with ascites, she has been started on neoadjuvant chemotherapy with paclitaxel and carboplatin. She received 3 cycles of paclitaxel with 175 per meter square and carboplatin AUC 5. And subsequently, we did her scan. Next slide. So, she has a partial response, but there's no evidence of any extra abdominal disease. She had partial response. So what next? Next slide. So how to proceed further in this case? Maybe Dr. Satinder will start with you. Dr. Satinder, how we are going to proceed in this case?
So post 3 cycles of neoadjuvant chemotherapy, since there is a adequate response in the abdomen, partial response, but yes, there is no extra abdominal disease, we'll definitely proceed with interval debulking surgery in this case. And we'll try to keep it section. Yes.
Okay. So, Dr. Rupinder, you are there? Dr. Rupinder?
Yeah, I'll answer all your questions.
Yeah. So, yeah, Dr. Mohit?
Yes, sir.
Yeah, any other opinion, like post 3 cycles?
Yeah, I think cytoreductive surgery with HIPEC, I think is possible, because it is shown to increase PFS as well as OS benefit. If
so there is one trial which has come up by Wandril et al, which has shown an advantage in PFS as well as overall survival advantage in interval debulking settings, especially if you are able to achieve less than 1 centimeter of disease, residual disease in the abdomen. But definitely there is an advantage, but there are many pros and cons associated with the trial. There's many fallacies in the trial also. So as of now, for all patients going in for interval debulking surgery, probably this may not be recommended. But yes, it has shown advantage, and if the patient is eligible and if you are able to achieve a good R0, HIPEC can be considered in these cases.
So great, ma'am. That's what I wanted to know, that basically what is the role of HIPEC in this, and that's what rightly said by Dr. Mukesh also, that and as you also, that HIPEC, there's a role of HIPEC. So, madam, could you please tell us what are the current indications of HIPEC
So currently, there is not much role of HIPEC in primary as well as in the relapse setting. The only positive trial which has shown is in the interval debulking settings. Definitely, there is one trial only mainly which has shown these advantages in PFS as well as overall survival. But as I said earlier, this trial also has many fallacies, especially the based on it was entirely dependent on the surgeon. The randomization of the trial was done on the day of surgery after at the time of surgery, and it was basically based on the surgeon itself also to choose. And this trial took a long time for they took around 275 patients, but this took a lot of time for this trial to actually take on the patients. But yes, all said and done, this trial has shown advantage in both PFS and overall survival, and we can consider doing HIPEC in interval debulking settings, but not as of now in primary or in relapse settings.
So, ma'am, even if there's any diffuse peritoneal disease wherein we suspect, like, after having a good partial response, don't we consider doing a HIPEC along with the debulking surgery?
Yes,
I mean,
if we are able to achieve an R0, if we are able to achieve an R0, we should consider doing HIPEC during interval debulking surgeries.
Okay. So, anyone from the panel, would you, ma'am, please tell us any one of you, who are the most eligible patients for doing this HIPEC, and is there any contraindication of in some patients that we don't do HIPEC? Is there any relative contraindication wherein HIPEC is?
So the relative first is the performance status of the patient. It is very important that performance status should be good. Patient should be able to tolerate this extensive surgery because definitely the duration of surgery is increased by almost 2 hours. The ICU stay is increased. And secondly, the most important thing is that resection should be optimal. If we are not able to achieve optimal debulking, there is no point doing a HIPEC in any of these patients.
Okay, fine. So we move on to next slide. Next slide, please.
Yeah, can I make a point here?
Yeah, sir. Please.
So we will be giving cisplatin actually during chemo. So we need to see actually cisplatin eligibility as well. Probably that we look at on a routine practice.
So right, I feel like I guess we all give carboplatin upfront in a ovarian patient. So basically, what you are asking about is during HIPEC therapy. That's what you are saying.
Yeah, during HIPEC therapy, because this cisplatin is ototoxic, it is nephrotoxic. Somebody having borderline creatinine, that we need to look at. The dose of cisplatin is very high. It is like 80-100 mg per meter square actually to be given during HIPEC. So these things should be, I think, kept in mind.
Yeah. So rightly said, the rationale behind HIPEC is again the plasma peritoneal barrier is what we need to overcome. And most important, as told by Dr. Satya, ma'am, that it's a microscopic disease, and the what pharmacokinetic advantage of attaining this high concentration of chemotherapy drugs is almost 12 to 15 times. So, in addition, this high temperature also increases drug penetration, provides a synergistic effects with intraperitoneal chemotherapy, and that is the basic rationale behind HIPEC. Because now, like if I say about the indications of HIPEC, then gastric cancer with peritoneal, colorectal cancer, then ovarian cancer with, and then pseudomixta peritoneal. These all are the recent indications of HIPEC. Rightly said. Next slide, please. So this lady underwent a debulking surgery with HIPEC, and she completed remaining 3 cycles of adjuvant therapy. Now, if you remember, I've told in the history that her mother has a metastatic breast cancer, and that's why treating oncologists thought of doing a Bracha mutation, Bracha testing. And this lady was found to have germline Bracha mutated. Now, before going to next slide, I would like to ask all the panelists, what's the frequency of doing Bracha testing in ovarian cancer patients nowadays, like in past 2 years maybe?
I think we do it any patient diagnosed, any patient presenting with COD, we do it for all patients, irrespective of age.
Yeah, so rightly, before this, like we are doing only for young Tnbc's breast, but nowadays recommendation is to do each and every patient of ovarian cancer, irrespective of age. Right. So let us just discuss 1 or 2 slides about Bracha testing. So would the tumor Bracha testing be an option for you? Yeah, Dr. Wasim.
Yeah, it was an option. Really, we struggled actually with this Bracha, with this somatic Bracha earlier. But now with the advent of our HRD, I don't think we need a Bracha testing program.
Okay. Any difference of opinion about other panelists? Tumor BRCA testing is an option. So for everyone, I assume that I presume that the tumor BRCA is an option, right?
Yeah, I think
Yes.
somatic testing is most important, I think.
For
So I
the patient management is important.
Okay. Next slide. So which one do you think is the ideal approach to maximize the patient's benefit from PARP inhibitor and why? So like, right before this, we have Dr. Piyush's lecture and he told very nicely about the PARP inhibitors, indication and all. So of all this, like germline, tumor test, germline followed by somatic, tumor test followed by germline test, which I'll ask each of the panelists, what do you think is the ideal approach to maximize the patient benefit from PARP inhibitors and why? Since this patient is a germline BRCA mutated, how you approach if this patient is with you?
Yeah, can I answer actually?
Yeah, please.
So I think the data which started with study 19, actually, it was all about the germline testing, and then came the HRD. And the more data is with germline, and we have seen that more responses for patients who are germline positive, who are BRCA1 and BRCA1 positive. And if we do a germline BRCA1, BRCA2, I don't think we need to go and look at a somatic mutation for that.
Okay,
so I think germline test is enough at the start.
Okay, so you feel that germline, if positive, is good enough to, I mean, there's no need to do other testing.
Yeah, if you have to start, sorry.
Would it a tumor tissue BRCA mutation is more helpful than a germline one?
My take is different in this regard. I think that tumor test followed by germline looks more reasonable approach, because actually we are supposed to decide the treatment for the patient and we'll think about family later on. So if we found the mutation in the tumor, then we can confirm that whether it is germline or not with the blood analysis. And if it is positive, we find HRD, then of course we are having the option of niratinib, and we found BRCA, and not using bevacizumab, then olaparib alone, and if with bevacizumab, then olaparib plus bevacizumab in the HRD positive setting. So I feel tumor followed by germline.
Okay, so tumor tissue followed by germline by Dr. Mohit. Dr. Wasim said it is mostly germline. Any other difference of opinion among the panelists?
So,
yeah, ma'am.
Yeah, so tumor tissue will definitely find more mutations than the germline testing alone, because tumor test will find both the germline and somatic. Around 20-25% additional mutations would be found in tumor tissue. But it actually depends upon affordability of your patients also. Just getting a test done is not enough. Your patient should be able to afford the drugs also. So if you are targeting the patient, your patient is affordable and you are planning to give PARP inhibitors, definitely you should go in for tumor testing along with HRD. But if your patient is not affordable and you're doing it only for the benefit of the family, genetic testing alone is good enough. Right.
Okay. So yeah, rightly summarized by Dr. Satindar Madam, that it all depends upon the financial stability of the patient, and also, I mean, how far we have to go, and what Dr. Mohit said is also right, that, we have to first think about the patient perspective first. We are doing this genetic testing, right? So we move on to next slide. Next slide. So basically, since the tumor identifies both somatic and germline mutations, do you think testing tumor first for BRCA would be advantageous for treatment decision? As answered by Dr. Satindar ma'am. So next slide. So what are the reasons for not opting for tumor BRCA testing? Is it because of the lab which offers tumor very few labs, or not confident on tumor BRCA testing? The accessibility is not there, or is there a lack of scientific evidence? Is Dr. Wasim?
Yeah, I think all of the above actually. That's what my take was. We do BRCA1 first. If it is positive, we have to put that patient on olaparib actually. So when we have so many challenges at present, do we need to look into that if the patient is BRCA positive?
Okay, fine. So let us not discuss more on this now. We'll move on to next slide. Next slide, please. So this is just to give an insight on germline BRCA testing may miss some of the somatic mutations in epithelial ovarian cancer. So this is the paper which has been published in Cancers in 2019, where they said that almost 21.7% pathogenic or likely pathogenic mutations were identified in tumor only. And these alterations would not be pinpointed if only a germline blood test, Bracha test was performed. So you can see this, a germline 18, and negative you can see, whereas for the tumor Bracha, it is more likely to be positive. So the tumor Bracha test had a success rate of 19.1% with a median turnaround time of just 17 calendar days. So the tumor Bracha test could be implemented in a molecular diagnostic setting, and it may guide the clinical management of patient with epithelial ovarian cancer. Right, next slide. So now again we move on to a previous case. So what are the options? So she had a stage 4 ovarian cancer, 3 cycles, paclitaxel carboplatin, very good response. She underwent debulking surgery with HIPEC. She received 3 cycles adjuvant, and she found a Bracha mutation positive, germline Bracha positive. So what are the options for this lady? Is it just follow-up, chance of, or you would like to be olaparib maintenance for 2 years, or niraparib for 3 years? Yes, again I'll ask each and every panelist if they could answer this. So what are the options for this?
Carry on.
Yeah, if they can afford and there is no tolerance issue, we have all the 2 options, olaparib as well as niraparib.
You want to choose one of the 2, which one would you prefer? Cost is not
olaparib.
Ketan, cost is not issue.
Yes, sir, because of more experience with olaparib.
Okay. Yeah, Dr. Mohit?
Agreed.
Olaparib.
Agreed, olaparib.
Dr. Vasim?
More experience with olaparib, that might be.
Olaparib. Satinder ma'am?
Yeah, so sorry, I just missed it. So I think any of these, whatever the patient can afford, depending on that. If the patient is Bracha positive, I would still go for probably olaparib maintenance for 2 years or more. More data available the first solo one. I'm convinced.
Yeah. So any other panelists having difference of opinion? Anyone remaining? So everyone.
Yeah, olaparib.
Olaparib. So Dr. Mukesh again olaparib. So rightly said, since we have more experience with olaparib, we'll go for olaparib maintenance for 2 years or more. Next slide. So this is basically a solo one trial just discussed by Dr. Piyush, where they they randomized into olaparib versus placebo, and the primary endpoint was investigator assessed PFS, and rightly said. Next slide. Next. So you can see the median PFS almost 48% versus 21% of those who are on olaparib as compared to placebo. Next slide. Again, this is a median relapse-free survival. Again, median PFS olaparib, it is not reached versus 15.3 in a placebo. No doubt, there's a definite advantage in both PFS and RFS. Patients who are Bracha mutated with olaparib maintenance. Next slide. Next slide. We'll just skip this. Next slide. Next slide. So next slide. We'll just skip this because it's already been. So the patient was started on olaparib based maintenance therapy, and since all the panelists have said that they will start on olaparib, so the patient developed grade 3 anemia 2 months later. Now we'll just a few discussion about toxicity of olaparib. So how you manage the toxicity of olaparib? Since all of us have used olaparib as a maintenance, and everyone agrees that olaparib is the drug which can be given. So next slide. So how will you manage the anemia in this patient? She developed grade 3 anemia 2 months. Yeah, Dr. Mukesh.
So to begin with, in this patient, I am Dr. Mohit. To begin with this patient, I would like to rule out the alternate cause like iron deficiency, vitamin B12 deficiency, and I will start the supplement. And as you said that it is grade 3, then I will give the blood transfusion as well. And if patient respond to this treatment, then there is no need to discontinue olaparib, and I will continue with that. But if patient doesn't respond to awareness of vitamin B12 supplement and blood transfusion and develop again, say within 2 weeks or so, or less than a month, again develop grade 3 anemia, then I would like to interrupt the dose. And again, I will interrupt the olaparib and wait for the recovery. And again, if it gets recovered within 1 month, means 4 week time, then I will start with the same dose. But if it is taking more than 1 month time, then I will start with the dose reduction. So to begin with, it is 300 BD, but first dose reduction will be 250 BD, then it will be 200 BD if it recurs.
Okay, so this is basically the management protocol for the common adverse effect with PARP inhibitors. Any other panelists would take this question regarding
Mohit
the
has answered so well that nothing more is left to answer in this question.
Exactly. So that is
So
the way forward.
comprehensively.
Have anyone discontinued olaparib because of the toxicity? Like we need to discontinue drug for any patient?
If patient develop
I
grade 3
had
side effects.
discontinued in a couple of patients who had a very bad toxicity because they were elderly actually, and they couldn't tolerate actually lowest dose of olaparib. So quality of life was very impaired actually. So that's the reason I decided to discontinue.
Okay, sir. So next slide. Next slide. So these are the summary of first occurrence of most commonly reported hematologic adverse events, where you can see this anemia, almost 39%, neutropenia almost 23%, and thrombocytopenia almost 11%. And the median duration of first event like months was almost 2 months, around 2 months for the olaparib. For anemia, around 0.76 months for neutropenia, and almost 1 month for thrombocytopenia. Next slide. And this is how we manage the common hematology adverse event of olaparib. So basically supportive treatment, dose interruption, dose reduction, and discontinuation. So very less, only 6% of the patient needs discontinuation. Till date, I have never discontinued on any of my olaparib maintenance patient. And definitely patient with more than grade 3 events, almost 22% anemia, there's the most common side effect. Whereas thrombocytopenia and neutropenia is not that common. Next slide. So the most frequent side effects observed with PARP inhibitors are fatigue, nausea, and anemia. Whereas the drug specific with niraparib, no doubt there's severe thrombocytopenia and may require dose modification based on body weight, platelet count, and it might reduce to 200 milligram per day. Next slide. Next slide. So I'll just quickly move on to my next case. So again, is a 52-year-old female with abdominal distension, pain, and fatigue. Her CA-125 was 352. She's ECOG performance status 1. There's no relevant personal history. So on diagnostic workup, she was diagnosed with high-grade serous ovarian carcinoma, FIGO stage 4B with adnexal masses and thoracic metastasis. She again received neoadjuvant chemotherapy 3 cycles with paclitaxel, carboplatin, AUC6 carbo. She underwent a debulking surgery with bowel resection and splenectomy. There's no residual disease. This is R0, and she also did a tumor Bracha, which is wild type. So, what is the first line treatment for this patient now? And what about the maintenance? Let us move directly on the first line treatment and maintenance. After having a good response to chemotherapy, she underwent a R0 resection and she found to have tumor Bracha mutation wild type. So how you approach this patient?
So we can give 3 more cycles of adjuvant chemotherapy, and side by side we can do HRD testing.
Yeah, side by
side. Yeah.
Okay. Any other opinion?
I think we can think of adding bevacizumab probably here as well.
My take is different in this because bevacizumab was not the part of induction therapy, and there is no point of adding it later on after surgery. But if we have given bevacizumab earlier, then we could have think about giving bevacizumab. And as the bevacizumab is out, then HRD testing in this particular patient is not going to help much because irrespective of if it is Bracha negative but HRD positive, then we are not going to use olaparib. We are going to use niraparib, of course. And nira can be used irrespective of HRD status. It is HRP as well. Then also niraparib can be given. So if we are thinking about niraparib, then 3 more cycles followed by niraparib, we can go upfront.
We'll definitely get a peek into the usefulness of niraparib once we do HRD testing. I think we'll get much more information, much more prognostic and useful information about the benefit of giving.
Yeah, I agree. Prognostic point of view, it is important, but because the hazard ratio is different with the HRD positive versus HRP, but we can anyhow offer niraparib in this patient.
Okay, so and HRD testing, everyone agrees that one should go for HRD testing in this patient since she is at tumor BRCA wild type, HRD testing is going to help her. Yeah, next slide. Next slide. So what are the maintenance options for patient who receive chemotherapy with bevacizumab as NACT or adjuvant CT?
So no bevacizumab because it was not part of the induction regimen as was in the pivotal bevacizumab trial. So definitely a PARP inhibitor would be preferred.
So suppose this patient has if received bevacizumab in NACT, so what would be your maintenance option for this patient now?
Then olaparib plus bevacizumab as per the Paolo trial.
As per the Paolo trial, would like to give olaparib with bevacizumab.
Yeah, if it is BRCA positive or HRD positive, in either case.
No, so this patient is tumor BRCA wild type with HRD positive. So
yeah,
in that case, what would be your maintenance option?
Yeah, combination Ola plus Bev.
Ola plus Bev. Yeah. So rightly said, we have to give combination of Ola with Bev in this patient. Next slide. So tumors which have evidence of HRD determined using current level tests are more likely to respond to platinum salt chemotherapy and PARP inhibitors. Like we all know, testing for HRD is recommended, and it identifies a subgroup of women who have BRCA wild type but derive greater benefit from PARP inhibitors. And that's what we have discussed in our last previous case. Next slide. So this is the Paula 1 trial. Just now Dr. Mohit quoted this trial regarding, use of olaparib plus bevacizumab in patients who have HRD positive. Next slide. Next. So you can see the difference in median PFS in those who are HRD positive versus those who are HRD negative. You can clearly see the difference in PFS. Next slide. So again, this is the PFS in HRD positive, and this is the PFS in overall patient population, where you can see at a median follow-up of 13.8 months, there's definite benefit of using niraparib in HRD positive patient. Next slide. So these are few of the median PFS of clinical trials, in ovarian cancer. So you can see Paula 1, Prima, Solo 1, GOG, Icon 7. These are the PFS, but these are the ones Solo 1, Prima, and Paula 1, where there's definite improvement in PFS with addition of PARP inhibitors. Next slide. So this is the standard systemic treatment for newly diagnosed advanced ovarian cancer nowadays. So testing for somatic or germline, panel testing for all high-grade ovarian cancers, tumor HRD testing if somatic or germline BRCA is wild type. Then we have to decide whether to give, first decision is whether to give NACT or primary debulking surgery. If at all we decide to give carboplatin, paclitaxel, NACT, decision 2 is whether to add bevacizumab or no. If we are at then is the decision 3 is whether to add PARP inhibitor or not. And if we add bevacizumab during chemotherapy and maintenance, then HRD positive including BRCA mutated, add PARP inhibitor as per Paula trial. If HRD negative, continue bevacizumab as per GOG 021 and GOG 026 to Icon 7. If we don't give bevacizumab initially, then if it's BRCA mutated with HRD positive, again add PARP inhibitors as per Solo 1 and Prima trial. And if there's HRD negative, add PARP inhibitor or clinical trial as per Prima trial. So this is basically a standard systemic treatment for newly diagnosed advanced epithelial ovarian cancer nowadays. When we used to study that time, it was clear ovarian cancer, 3 cycles paclitaxel carbo, interval debulking, adjuvant chemo, 3 monthly follow-up. But now with the advent of these newer drugs and all the genetic testing, I mean, this is the way forward. Next slide. Thank you. So I thank all my panelists, and I would like to thank Dr. Sachin Gupta for giving me this opportunity to moderate the panel discussion. Thank you very much.
Thank you, Amol. You have done that so beautifully, and this is what I actually envisioned when I decided about this panel discussion. So most of these points have been discussed, which were actually very relevant in today's setting. I hope my panelists and other people will agree with that, because this is the trend, and we have to learn how to integrate this testing and these drugs into clinical practice. So thanks, Amol, for doing justice to this. And thank you all the panelists for sharing their views and giving their opinions And so all of us are actually, learning, and we are enriched with all this information here. And I also thank the, my support team and Horizon team for, helping me out in organizing this, gathering all these eminent speakers, moderators, and panelists together. And so we are actually slightly beyond time, about 15 minutes late, but I think it was worth it. And sorry for keeping you waiting and for being a little late here tonight. But I hope it's useful for everybody, and all of us have learned something out of it. So the purpose of the this virtual meet is served only if we learn. And so thank you all, and a very good night to all of you, and hope to see you again in some other forum. Thank you.
Good night.
Good night.
Thank you, sir. Good night.
Thank you, Survey. Great.
Support team, we can close the meeting.